All right, good afternoon, evaluation committee members and other parties of interest. This is the evaluation committee meeting and possible scoring for request for proposal RFP-24-24912, self-funded group health plan for the Human Resources Department. It's being held by means of communication media technology. Provisions have been made for members of the public desiring to have access to view the meeting. Public attendees must remain on mute and cameras off. For the record, this meeting is being recorded and the recording will be available after the meeting has ended. Please be advised that we are still in a cone of silence and that shall end the earlier of 5 business days after the county posts its notice of intent to award associated with the solicitation or on the date the procurement is canceled by the county. All questions, comments, and concerns must be directed to my attention and my attention only. As a matter of housekeeping, the technical advisors and project observers in attendance on media technology, please mute your audio unless you're speaking and keep your cameras off. If you called in, don't put the call on hold either. My name is Sakina. I'm the chief buyer for the project. Again, for the record, this is being recorded and will be and has been publicly noticed. I'm going to go ahead and hand this off to Scott Stromer, the director of procurement, for some important instructions.
But as a reminder, this is a follow-on meeting. This is a publicly noticed meeting. As a reminder for the public, yesterday in the morning and very early afternoon, you had exempt meetings, which were the interviews with the 3 offers, the 3 proposers. That recording will be made available to the public. It was not a sunshine meeting. So this is a continuation of the evaluation committee's time together to deliberate. From yesterday, I had to kind of go back to look at my notes and talk to staff. So the consultant had a redacted copy of their notes and their summary. So I had to go back and look at my notes. I think there may be some misunderstanding of why it had to be redacted. It did not have to be redacted. Because remember that the protection of that information is strictly that it does not leave this room. It doesn't go to the public. So the restrictions are not to put it up on a screen because the meeting's recorded, because they're going to see that. They can capture it there. When you're talking about it, don't verbatim read the proposal where somebody that's sitting there can discern exactly who said that and what their numbers were. Those are the only 2 restrictions. The committee has full access to that information in their proposals. I think each of procurement provided a side-by-side for everything we had, I think, early on in the process. So you saw kind of comparative those answers as well. It was there. So today, the consultant's going to give you their unredacted copy of what they provided yesterday. With the understanding they may have added some additional things or whatever, I guess. So, but I just want to make sure that we're clear. So if I was to give you some guidance, if you have that information there, it may be as simple as an example would be refer to page 5, row 7. You can see here the differences without getting into exactly what the detail is, who the vendor is. If you need to call out the vendor, you can still kind of mask that comment by doing whatever else, to kind of keep it on the high level. Again, it's not ideal, but again, the timing we have, because my understanding is it's going to take 7 to 8 months to implement this program. So we have a very short runway. So I need to keep this on task, move it along with a good solid recommendation for award to the board by the end of February. So I want to make sure that we've done everything we possibly can to keep this moving. If I had to deal with that whole disclosure thing, that would take no less than 2 weeks, if not several months, to get that litigated. So we're going to do it this way. And there's no reason why we shouldn't be able to do it. So hopefully that helps. So the consultant is here to walk you through their information. You have 4 hours a day. Given yesterday, I think it was still a good discussion yesterday. I think there was a lot that was gleaned from that. You can probably be a little bit more focused today because of what your discussions yesterday. You still have that meeting next week set aside on the 18th. So don't feel like you have to do it all here. If not to call Irma out, but for her benefit, certainly, she's kind of come to the party quite a bit late and she's at a disadvantage. If she needs this time, that 18th would be probably very helpful. So if you had to cut out here early, once you have those discussions, That way they can go back to their corners and they can review their information, go through it. Once you get your questions answered here, and then you can come back on that 18th. It's absolutely critical that you review the criteria. I think staff's going to do that with you today. That when we get through this evaluation, that it is very deliberate and it's reasoned. And so I want you to make decisions. If you need something from us, you let us know. Whatever you need. If you need more time, if you need another meeting after that, we'll make that happen. So, anything else for me? I'm probably going to leave you today. Not that this isn't gripping.
You like that word.
Yeah, there's just some other things going on. I know you guys all have important things too, but I just got to get some things, and I just see sitting here. But I'm on call, so if something happens, if I need to come down and somebody needs to yell at me for something, then I'll be here. Well, I probably wouldn't come for that. But I'm here to help wherever I can. So, any questions on me at all? We're in a good place, I think. So, okay, great. All right, I'll turn it back over to. Want to introduce, I guess.
Yep. So at this time, I do want to have the committee members, since we're a little bit more spread out today, introduce themselves. And I do want to start with the committee chair, which is going to be Tom Fessler.
Hi, I'm Tom Fessler. I'm the county's chief financial administrator.
Field, project manager with Healthcare Services Department.
Tim Pearson, President, Firefighters Union.
Cheryl Murphy, Human Resource Manager over Wellness.
Irma Muka, Budget Managing Director with the Management and Budget Department.
Mike Drago, Senior HR Partner for Total Rewards.
Donna Stark, Senior Functional Business Analyst, Enterprise Solutions and Quality Assurance.
We also have with procurement support, Christy Alessino here.
Procurement Operations Coordinator.
We have a few folks online. I'm going to let them introduce themselves on the advisors, please.
Ivy Martin, Human Resources Director.
Ernie Mayer, Assistant County Attorney, Labor and Employment.
I think that's it on the advisors that are online. Okay, and then for the rest of the room, let's go ahead and go around for introductions. And I think we'll go ahead and start right here.
Advisor Maria Liddy, HR Division Director.
Jamie Loeb, Senior Client Manager, the Baldwin Group.
Dean Kelly, Client Executive Leader, the Baldwin Group.
Nicole Nefetti, Managing Director, the Baldwin Group.
Rebecca Burley, Benefits and Retirement Manager, Human Resources.
Elizabeth Bollinger, Human Resources Benefits Partner.
Cindy Shukla, Human Resources Fiscal Manager.
Paul Almeida, Contracts Manager, Human Resources.
I think that's everybody that's either advisors or observers in the room. Neil, also an observer. I apologize, Neil.
That's okay. Neil Gemma, firefighter, local 2294.
All right, so we are going to be looking at 3 proposals today. So I do want to bring up that we, for the record, there were 3 proposals. Those proposals were from Aetna, Cigna Health and Life Insurance Company, and United Healthcare. Make sure we have that. The committee is going to evaluate, discuss, and score by consensus if they come to that point today. Those 3 responses that were submitted, each proposal will be evaluated based on the information provided in the responses as it correlates to the requirements and evaluation criteria that was set forth in the solicitation. So the responses are going to be scored based on the following criteria. Criteria 1 is the proposer's understanding of the scope and objectives, the technical approach, and the work plan presented. That is a maximum of 65 points. Criteria 2 is the quality of the proposed system and its ability to achieve the county's objectives, maximum of 15 points. Criteria 3 is the pricing and discounts, maximum of 15 points. Criteria 4, the proposers and organization's qualifications and experience, maximum of 5 points. And then criteria 5 is the bonus points for the DM, DWBE, SBE bonus points, and those will be announced after the committee has finalized all their scores, whenever that happens. That is evaluated by our small business team. The evaluation committee, Chairperson Tom is going to, in general, lead the discussions, but the committee members are all obviously willing to discuss as they need. But general guidance on the evaluation and scoring. You can score, Tom, by category, the way it is here, by one proposer at a time, by one category and the three together, or however you guys feel it's best to kind of evaluate that. So that's for you guys to discuss those categories. When you do score, if you score today, please make sure that you state your final consensus score that you agree upon today so that I can record that. And then at the conclusion of the scoring, I'll verify all the scores with the committee one last time before we leave. And then with that all said, I think I will go ahead and hand it over to Tom if you want to say anything to get started.
I think maybe.
Did you guys all have one?
Maybe if we could start by just kind of going back over some of the information we went over yesterday with the unredacted information.
Sure.
Yes, the committee was supposed to be, I'm sorry, the consultants were bringing back the unredacted version. And have you already handed that out?
Yes, you just did, yes.
Okay, and you have a copy for us?
We do?
I want to make sure.
Do you need it now? Okay, I guess that makes.
Yeah, Tom, you can go ahead.
Do you need it for?
No, we're
We
good.
have,
Okay.
we have.
Yeah, we all.
Thank you.
Yep, we're good.
Thinking maybe if we go back through it, then anybody can just ask questions as we go.
Okay,
We went over yesterday and then go from there.
okay. Do you want us to lead that or do you want to? Okay.
Yeah.
Have to have a copy of that?
I don't know that they have enough.
If they have them, but.
Do you have an extra copy?
That's okay.
Cool.
May I share? Am I allowed to share with an advisor? Yeah. Okay, I just want to make sure. Well, this doesn't want to. Do you want to take mine? Becky and I can share. Jamie and I can share.
I mean, plus I have the one from yesterday, so.
Oh, yeah. I mean, it's the same thing. Honestly.
Yeah, I mean, I have both, so.
That one includes the geo access.
I can always, I don't necessarily have to have it.
Jane, how does this differ from the one we received yesterday? Is it?
It has the information. It's unredacted.
Right. Other than that, is it?
The Q&As are not included. So like everything that we compared with the ASO, PBM, behavioral health questionnaire, that is not included.
There you go. But it's a little smaller.
Okay, does everybody have a copy? Do we want to? Okay. So I'm going to actually be a little, I think, less or more vague in my spoken language now that everybody has numbers in front of them. We can see that there's three proposers on the page. Just kind of as a reminder, what we did is look at each one of their responses and try to bucket them. We identified, by no means is this a representation of every single thing, but it is the things that we know as your consultant to be of a top priority or of a scoring component of the RFP. So what we've done is highlighted that information in a red, yellow, or green fashion. So comparing each of those bullets to the left or the right or the center, how do they compare to one another? And they are either, go.
Can I just ask a question?
Yep.
For those of us who do not swim in this pool all the time, can you spell out acronyms when you use them throughout?
Yes.
Thank
you. Stop me at any point if I don't, because it's literally second nature. So I will try, but yeah, just please feel free to interrupt at any time and say, speak English.
Thank you.
So ASO is administrative services only. All right. So this is who are you hiring to manage all the data, process all the claims? Of course, you guys are self-funded, so you're paying those claims, but it's who are you doing to, or who are you hiring to push all the buttons, so to say? And it is one of the three proposers, and they're going to do all of these different components, but you are going to be assessed a fixed flat fee. That's your administrative services only fee from each one of these vendors. And it will be their charge for pretty much everything else that we do, we talk about from here on out, except in areas where we say, hey, that goes towards the financial credit or reward, or that's an upcharge, or, we'll point that out. So as you can see, the first bullet, so just the administrative services only, the per employee per month fixed costs that it'll cost the county, you can see green, red, yellow as you go from left to right. The length of the rate guarantee from left to right, green, yellow, because the other two are equal in length. The rate cap is that is saying for how long is that number above? And I guess I should say the rate guarantee, right? So the number you're looking at in the first bullet, how long is that guaranteed or locked for, right? So the number of years is bullet 2. At that point, when it is outside of a rate guarantee, then what is the maximum that number can increase for each one of those vendors or responders? Green, red, yellow. Credits and financial resources. So this is how much money are they going to provide to the county to fund some of those, I'm going to call value add resources or resources that aren't necessarily line items in your budget or your health plan budget. So they're dollars you're asking them to provide as a component of doing business together. So from left to right, you can see bullet 1 would be an annual commitment. Now, those annual commitments, again, if you were to go back into the responses, you may see a number that's an annual commitment that's bucketed or in 2 different numbers. It would definitely add up to the one combined annual number I'm giving you. But I'm trying to reflect for you in total, what can you expect annually? When I say I, we, us. The second bullet would be one time or maybe every couple of years. You can see on the left, there's it's not necessary. There's an annual commitment that is above and beyond the first bucket. And then there's a commitment of an additional opportunity for 3 times within the 10-year contract. And then the other 2 responders, you can see that they have either listed one time or no additional credits. Everything's all in on the first bullet. Yes.
Pardon my math. If you have an ASO of 1.9 annually, but you have a credit of 2 million,
Yeah.
how does that math out?
Well, the 2 is paying for other things. It's not paying for, so you're paying them to administer the claims. That 2 is going to pay for the clinic, the on-site,
Where does that come from?
they're giving those dollars. I mean, it's the carriers, that's from their financial bottom line.
So taking in 1.9 million, but giving back 2 million.
Be
That
very
doesn't seem like
careful
a,
with specific numbers, please.
I'm sorry. So how, okay.
Supplemental question to his. So could those figures be offset by additional fees that they're being charged elsewhere
Yeah.
within the product?
Yeah.
Absolutely.
Not necessarily accounted for on page 1.
Okay.
Yeah, and I think I would zoom out for a second to just when we look at how carriers, they are for-profit organizations, right? And so they are going to collect, there's revenue collected in a multiple number of places within everything that they're proposing to you. Like within a pharmacy contract, there's revenue being, not for your consultant, but they are a for-profit business in every area of their business. They are, in essence, making some profit somewhere. All of that is already included into what your all-in cost is, right? So what we're saying is this is how much it's going to cost for your administrative services, but they're thinking about the profitability of any client when they propose any sort of partnership with a client.
So when we're trying to compare apples to apples, is there an adjusted ASO that would show value of expected fees or anything else?
They're not relative to one another.
Yeah, so think of it completely separate from the fund that they give you. They're
Well, I had a similar question though. So is it fair to say that in the example that was just given, if you take those 2 numbers and add them together and then compare them in total, some of them might be giving you a higher ASO fee, but less on the backside. But we're still paying everything. We're self-funded. We're paying all that. We're
Yes.
paying for it. We're paying for it somewhere.
Agreed. Those other, so 2 of those ASO fees include the clinic, 1 does not. So it's really hard to, and that's why yesterday when we ended the day and we're like, it's really hard to roll all these numbers up to one another. They have to be looked at individually. And I would probably just go back to this, like, this is important and we've got to get through it. And I want everybody to feel comfortable about where we land. But at the end of the day, the scoring, this is 15 points of the scoring. I think we probably need to spend, when you guys are ready to score, a lot more time talking about how we feel about it. We'll talk about this as much as you want, but the relevance to point value is probably going to be far heavier weighted on things that are outside of that.
Yeah, I think part of it is it kind of, to me, it feels like even though this is dollars and cents, I think what I'm hearing from various committee members, and I know I feel this way, is we're looking for the value of what we're getting for that. So for example, if I think I'm ordering a Supreme pizza, but I end up getting a cheese pizza and all the toppings were extra
Yeah.
that I didn't realize, then that's a conundrum. And we've put in place a situation that we definitely did not want. So I think that's kind of why we're all trying to figure out what is included in that number, because the numbers can vary greatly between proposers. So like we are kind of trying to figure out what belongs where to make sure we are getting our pizza with all the toppings from the get-go.
Yeah, I mean, I think that's a great point. And I think, again, to Jean's point, it's hard to kind of roll all this stuff up because, there are many different programs that are going into some of those credits and financial incentives that you're being given, right? And that's where we're coming back to some of the ASO questionnaires and really when we're discussing kind of behavioral health or any of those things, the clinic, that's where I think you'll see a lot of this play out. And that's where I think a lot of these funds are going. Additionally would be marketing support. I think there's what is the other one?
Wellness dollars. So
Yeah,
there's wellness dollars.
So it is, and I think that's where, if we look at the proposers, they are providing a level of value that you're seeing now, right? And I think part of this was to say, hey, are there significant differences that would say, wow, that's a big enhancement to where we are? But again, less focused on the actual dollars here.
So what I would,
very hard to explain.
yeah, and I think, go ahead, Jamie.
Can I just point out that if everybody references page 47, you're going to see some options.
Well, I think it's different in here. Hold on.
Oh, I'm sorry, not 40.
She's looking
47
at
on my
yesterday.
end. What's it within the
Give a header across.
It's page 7, beginning on page 7.
EMC and spending accounts?
Again, what is it called?
Have that?
No, it's, so you do have page numbers on, 7 is left off, but there's page 6.
Do we have EMC and spending accounts in the?
Yeah.
So it says the number in the lower left.
Okay, I'm looking at yesterday, so I have our
Page
version of
9,
it,
page
page 9. So you'll see some of these add-on services that would be coming out of those buckets of money. So this is where you can see a more side-by-side comparison.
Well, I would, great point, Jamie, and I'd actually, so that's page 9,
I'm
right?
not trying to jump ahead, but I think that might help to answer.
The value that you're looking at is a position. So the county may not have the budget to hire a nutritionist. The funds are coming out of that fund to help that position. So we're getting a nutritionist or an employee that we'll be able to utilize from those funds. So you think of the value of it that way.
And the other-
we would not be able to do on our own.
I was gonna say, that's just an example. Yes. I think one or maybe all three actually do provide a nutritionist. So
I
I
was
think
thinking
but that's an example.
But it's not something that if, in the absence of having that, those things that those funds go towards are things that if you didn't have dollars from someone giving it to you, you wouldn't be able to provide that as a resource to your employees.
Yeah.
So, yeah.
Can I see advisors? How are the funds being used currently that we're receiving?
They're actually delineated automatically. This is a different kind of proposal where they just say, here's a block of. So, right now, I'm not sure don't think I can give numbers.
I can give numbers on wellness.
But can we say numbers out loud?
Of what we currently have?
Are we allowed that? Okay. Okay.
So right now, our current provider gives us $211,000 annually to do wellness programming. So that pays for things like Wellbeats, Navigate, those things that you're familiar with if you use the wellness program, our professional series fees, things like that. That's what we use those funds for. So I can speak specifically on that. Part of the minority funds are being used for COBRA and retirement administration, printing, water bottles, on-sites, things like that. Yeah.
And wellness went towards the fitness center, correct me if I'm wrong?
There is an innovation fund that is not part of that wellness fund.
Yeah, that was in the most recent contract modification negotiations.
And that pays for things like repair of equipment and things like that.
Yes.
And that helps to have that information because when we're evaluating, oh, what this is coming back, we know that if we choose an option, what kind of impact it may have on what we're currently offer, or we may have to get funding from an additional place. And that's, I think, important for our deliberations.
Yeah, I think if I could just zoom out for a second, because like taking all of this in, I think let's look at it at this next couple pages a little bit differently. If we go back to the executive summary, I feel strongly that, and you could, now we all see, like, I think this conversation highlights why it's really hard to roll all these up into one. So I feel really strongly that you've got to look at, from when you're looking at just pricing, right, which is a very small piece of your score, but when you're looking at pricing, you've really got to score the first page of the executive summary. Like, what is pricing? What are we spending on ASO? What are we going to spend? And we'll come back to it. You won't find this number yet, but like, what are we going to spend on claims that we're going to pay? And what are we going to spend for medical claims? And what are we going to spend on pharmacy? Those three numbers together, I think, help you get to a financial dollar that you could roll up into one, right? Then on top of that, what resources are they going to give us to fund all these other things that aren't in our budget, right? And that is the other bucket. Now, if you flip back to beginning on page 7, which doesn't have a page number, but 8 and 9 do. If you look at pages 7, 8, and 9, that is a side-by-side comparison. And now what we put in green here, and forgive we're limited to how many colors we can put in our presentations, but when you look at green here, so this is a list of like pretty much all of the things, or 80%, 90% of the things that really matter in the contract. The areas in green are being funded by the dollars they're giving you, the resources. So if you look at the top, you can see in green from left to right, how much financial resources, which correlates back to the bucket a couple pages back that was the second main bullet or second main point. And then as you go over these next 3 pages, you can see anywhere highlighted in green means it's coming out of your financial resources.
That makes so much more sense to me.
Okay.
Thank you.
Yeah, you helped me get there.
I have a question for you, and you may have answered this yesterday. I'm just
That's okay.
recalling the answer off the top of my head. When it comes to the PEPM and there's a dollar figure listed in the columns, is there a set head count that you used, or was it an amalgamation of?
Excellent question. So if you look at the top, all of them used, well, for the purpose of developing that PEPM, we used a number that we believe to be accurate in our analysis, right? I'm going to point out where we did not feel comfortable or feel like it was our place to manipulate data would be when we get into claims repricing or prescription repricing, where they think that they said, here are the number of scripts or here are the number of claims that we repriced. We used the numbers that they provided you and did not edit that information. So you'll see different numbers, and I'll get to that in a second. I'm kind of jumping ahead, but for the purpose of calculating that total annual ASO fee, we used a number that was consistent across the board so you could compare apples to apples. And know that your employee count literally changes on a daily basis. It goes up and down based off of hires, retirements, separations. Yeah, great question. So I would like to spend some time on those 7, 8, and 9, but let's go back to the executive summary for a second if we can. Bucket 1, I think, is a component of pricing scoring, right? Bucket 2 is a component of pricing, but it's also like the proposer's understanding of your scope, your objective, like the things you said you needed from them in order to be a partner, right? So I think those two, play in together. The premium concierge model, you can see that it's consistent across the board. Now, remember yesterday there was one proposer that did not have a 24-hour. So that's something to think about. And this is where we can go through this and we can help you point out where we think this is going to fall in your scoring buckets. And some of those scoring buckets are going to be things that you guys are going to have to talk through what's important to you. And we'll help you with that dialogue, but there's not going to be a black and white number that we can point to that say, this is better than this. Right. The medical. So now this is like processing. How are they processing medical claims? How much are you spending on claims, right? Like how much are you getting in discounts for using their network? And how much are you sharing in recoveries for subrogation, overpayment, billing audits, things of that nature? Subrogation is if there's somebody, another responsible party to pay that claim, and maybe the proposer, your health plan paid the claim inappropriately, and then you find out, wait, that was an auto claim and they should have shared that. That's like, hey, we're going to go back and fix those dollars. But the proposers are saying, for doing that investigation, we're sharing in some of the recovery with you. Same thing with like a claim overpayment, or if there's an audit of providers' billing that is inaccurate, those things of that nature. And you can see, I skipped to the very bottom bullet, sorry, but I just wanted to explain what that bullet means. And we've highlighted yellow, red, green based off of the amount of savings they're willing to share with you. The repricing again, and we'll show you in a couple pages why we're saying that is negligible, meaning they're within percentage points of each other. The capitated claims. So one proposer, confirmed that they do capitate claims. The network discount guarantee. So again, they're saying how much do we guarantee we will discount, the billed versus paid claims for you. And if we miss, right, if we miss that number, how much fees are we putting at risk?
Find out again though, like they're going to hit that number, right?
Yes. Yeah. I don't want you to.
Extremely important for them to hit that number,
Yeah.
and for you to have them hit that.
And so when we're looking at like rolling up a budget, we're not going to say, okay, well, there's another $500,000, and I'm just
Right.
throwing out a number. There's another $500,000 that we get back. This is a protection. Nobody wants to hit this number. I wouldn't budget for it. Yeah. The copay only, right? So a lot of the things that we've talked about with your HR team is how important it is to be innovative and be on the vanguard when it comes to plan design and plan offerings. And one of the things that we've talked a lot about with your HR team that they know because of market research and employee dialogue, they know to be true is that people are really interested in what we call first dollar coverage or copay type plans. And so those are things that we continue to explore with them as your consultant, but also have to balance that. Can traditionally for many years, you hear the word copay and you're like, okay, that's a more expensive plan, right? So how do we come up with a solution? And everybody has one, but only one of the proposers gave you a solution that was tech enabled to ensure that we're providing that value to the employee without losing sight of cost and quality. And they're rewarding employees for making that good decision. Remember that left and right turn based off of their network and a lower first dollar coverage opportunity for the employee. I don't think there's any guarantee. This is another like future what if. It's a wish list. It's important. It's not something that you have today. It was something we knew we needed to think about in the future. And I don't know if anybody else who's not the consultant wants to speak to that at all. Or if that's an appropriate question, we can move on. Nope. Okay. We talked about the provider disruption. So yesterday we heard from all of the proposers their ability to waive certain prior authorization restrictions. That does differ from what was in the written proposal. Our evaluation or our color coding is based off of the written word and what we heard in the proposal. And then yesterday we had called out to you that the middle and last column for that very last for the subrogation, those two needed to be reversed. That's corrected. Like you're looking at the right colors today.
Thank you.
The pharmacy. So we broke down again, pharmacy is a very, we could literally spend 3 days just talking about a pharmacy contract and not get through all the intricacies of the pharmacy contract. What we did is took that all of the responders were asked to fill out a pricing and savings analysis. And we took the key components from that on a 1 year and a 3 year basis. This is looking at everything on a 1 year basis or year one going into it, because that's what we're looking at from claims and all of the other things. But we broke down whether or not it was a pass through, whether or not, and that means is the county benefiting from the pharmacy benefit manager's price for the drug, or is there some sort of spread in there? Again, the proposals we had suggested one thing. Yesterday, we heard a little bit different. This is going off the written word from the proposal. But when you get into ingredient cost, and we'll show you in just a couple pages back where we've broken these numbers out, or where you can find these numbers, but we then compared ingredient, dispensing, vaccine admin fees, per script admin fees, and whether or not grandfathering was allowed. and we're comparing red, yellow, green from left to right, who is shining or benefiting the county the most in those areas. And I'll show you in just a second what the numbers are for those areas. On-site resources. So the on-site resources are funded by one of your proposers in their annual financial resource. The other two proposers, they're funding some of that with the admin fee at the front. So that's why it gets really hard to bundle these numbers up together. And then finally, performance guarantee. So kind of everything that we're going to look at for the next couple of pages and what Jamie was pointing out, all the things that they're agreeing to do for you, and even the things that we're not talking about today, which are how quickly are you going to get ID cards to our employees? How quickly are you going to process claims? How quickly is your implementation going to go each year at renewal or first year if we're moving to you? All of those things have individual dollars at stake if they miss certain metrics. And we've defined that for you and rated them based off of the fees at risk. Service and fee comparison. So I'm not going to go through line by line here because this could take all day. It really could. These are all, it goes back to that ASO bucket, right? Administrative services only. What things are included, what things are not included, what things are being funded by the financial resources. And we've broken it down in a similar order to what you saw in the executive summary, but we're looking at how much are you paying them to do all these things? How long is that guaranteed for? What do you get in financial resources on an annual basis? The medical claims administration, like what things are included? Subrogation, what's included. And again, this is, when you look at this, this is what the carrier share of savings is. I've adjusted your executive summary to be what the county's share of those are. So focus on the information in the executive summary. The pharmacy claims administration, what's included, what kind of contract it is. Eligibility management, reporting services. So this is like, it goes back to, I think Donna pointed out some things yesterday, like what are the carriers, and this is important when you get into your questionnaire bucket, because that's where a lot of your scoring is weighted. Are they able to provide the county the resources, the reports, and the tools necessary to easily administer this plan? Or will there be some sort of disruption to you, or heaven forbid the employees, because not having access to a certain piece of information? Or the information in the format maybe that the county is expecting that will communicate with some of your technology systems. The network guarantees, again, next page. So we're breaking out we showed you in the executive summary, like we compared the discounts based off of like the aggregate of all, but the carriers are breaking all of those out by like, what do we guarantee when you're at a facility, ancillary and professional services. Claims. So I'm not going to use any of these numbers, but this is really important, right? So this is taking, and again, it's really hard to take this and roll it back because they're just looking at different things. But what all of the carriers were asked to do is taking about 2 years or 18 months of your data. I'd have to look. It was 12.
No, it's more than 12.
More than 12. Yeah. I'll look at that. We can look at that in a second. But what we did is say, here are claims that were processed and paid by our current vendor for a certain period of time. Rerun it through your network and tell us what we would have spent. And I really would draw your eyes down to the bottom line total and the total allowable aggregate. And you can see they're all very close to one another. And basically what they're saying is, here's what we think that would have been based off of the discount, the new discount we're proposing to you, or the discounts in our network. This is important and this is real, but no, this is a snapshot of history being projected in the future. And there's no guarantee that people use the planning. We can make an assumption based off of your size that it's going to be pretty similar, but this is not a guarantee of cost in the future. Does that make sense?
It's a reference tool, basically.
Yeah. Yep. That's why, yeah, like it's just hard to say, okay, well, here's the all-in number for these things. And then again, if they miss any of those discounts, what are they willing to put at risk? Like how much fees are they willing to put at risk? We don't want them to miss on those numbers. We want, because this is your money, we want them to hit those discounts. They want to hit those discounts because they don't want to lose their fees. The employee medical clinic and spending account. So good example of like how everybody's doing things a little bit differently. I'm just going to draw down to at the bottom, spending accounts. We spent the least amount of time on those yesterday because they're just pretty basic, cut and dry, your flexible spending account, your health savings account. There is a per member per month fee for that. Some proposers are saying, hey, there is, and you can use some of our, our financial resources to pay that. The county can do whatever you want. I would argue if you're not doing it today, I would take all those dollars and keep continuing to commit those dollars to the things that aren't a line item in your budget already.
Yeah, I have a couple questions about this section. So the PEPM that's listed here, is that across all accounts or simply one of them like an HSA or what have you?
For the FSA, the limited purpose, so that would be per enrolled employee per account.
Right.
For every type of SSA account.
So I'm asking if an employee has, let's say, a limited FSA, dependent care, and an HSA, are they being charged, or the county or the employee being charged $389 or $330, whatever the amount, that $2?
So if they have both accounts, they get two different, FSAs are a bucket, HSAs are a bucket. Yep. So, but you could have, when we say per account there, you could have 3 different type of FSAs and you're just paying that one $389.
Right.
If you have an FSA and an HSA, you pay both.
Yes. Okay. Next question. Is there a generalized number that it was, you kind of like we have the 5,518 at the top. Is there a standard enrollment number that we used or can be used to calculate? What
I would look to your maybe consultant or not your advisors. It wasn't included in the proposals like that we shared with the market. They don't need it to rate their product. So we don't have anything today that we could share with you, but I don't know if the technical advisors would be willing to share or could share like, hey, today we have X number of HSA accounts or X number of FSA accounts.
Off the top of my head, I'm not sure. Mike, do you know?
I mean,
there would definitely be one for everybody that's enrolled.
Right. Right. So I mean, like, I just wasn't trying, the
So
purpose of the question is like,
3,000 people.
if there's a set ballpark number that was used, like there is for the 5,518, we'd have it for reference for calculation. If there's not, is there any kind of recommended number? But
Around 2,800.
yeah, I know like for Modern Plan, we're around 2,500, give or take, in any given month. And it's easy enough to obtain the information. I'm just asking for.
Not that we have to share today.
Exactly. Thank you.
Yes. I would also point out too, and still good question, and the total matters, but also like today, never mind. I was going to say it's not, it depends on who's paying that money. It's already either in your budget. So I would really focus on, are we going to spend more if we move or are we going to spend less? And you can tell that by the PEPM. Enrollment counts probably wouldn't change.
Right.
And then, sorry, I skipped a lot. So with your medical clinic, and again, at the top of each of these 3 pages, we're recapping who we're talking about and what financial resources. And then again, anything highlighted in green on these 3 pages are things that you're going to have to take that bucket of money and allocate towards. And you may or may not be getting it that way today. It's, so you have to decide. An example of that is we've talked a lot about behavioral health and an on-site EAP rep. You don't have that today. So with any one of these vendors or any one of these responders, you would be adding an additional line item towards the money that they're giving you, right? And do you want to do that? And that's something you guys have to decide.
Donna, were you asking how many people we currently have in like FSA and those?
I was asking if there was a given that they use a range of data, to calculate the number at the top. I was wondering if they had a specific number that we could calculate, the PEPMs offered to come up with like a general reference like we've done in other places in here. If there wasn't one used, again, we can go back and figure out what that is or pick a month or what have you. But again, I'm just looking for like a reference. Oh, where is this falling? Big picture, how,
I looked for the same thing, and there was a utilization report provided in some of the voluminous documents. And for the previous year, FSA usage was 1,128 individuals, and HSA was 2,527.
Can you share just where in the?
Oh, gosh.
Okay, that's okay. Then never mind. I just don't recall us providing that. So, but it could be hidden in a claims document somewhere.
It was contained in one of the exhibits. that
Okay,
was provided.
okay,
Right now, we have roughly 1,400 FSA participants.
okay. And then I think what was the HSA number you used? I know Mike said about
25.
Yeah, that sounds, yeah. And I think if you use 2,500 and you use 28, it's all, the PEP, it's all going to be relative. You're going to come up with one is still less than the other, one is still.
Exactly. It's just, I'm looking to reasonably walk the math through.
I talked through that really quickly. Is there anything, do you guys want to pause for a second and just talk about any of this? Questions, thoughts?
Where does the decision-making happen for the credits? How that money is spent?
That's a great question. I would say the HR team. I don't know if we can answer that or the technical advisors. Is that something the committee's expected to answer or the HR team?
Repeat the question, please. And Madam, please. I'm so sorry.
How will
When we're talking about the a la carte and the credits and things that we're going to spend that money on, who ultimately makes that decision of where that money's going?
Yeah, it's usually the Ivy Martin and the HR team
And is it
who's going to administer it and all that kind of
Is
stuff.
it a lump sum credit or is it a use it or lose it sort of thing?
No, we asked a question in the RFP about it rolling from year to year. And I don't recall the answers from all three of the proposers, but we would use it all.
I don't think we've ever not used the money.
No.
Over a lot of data analysis with another system called Artemis, and then we look at where programs are needed, and that's how we make decisions on where the funds should go.
Okay. I didn't know if it laid with the carrier or with the HR department.
Each carrier looked like they did identify what those funds could be used for, which buckets, so we would determine how much of it goes in those buckets, but we are limited based on what they're also saying. So it's not that we could just take that money and use it for, give them a
Right,
raise, we can't do that.
I
Because they
would
do limit
imagine-
with buckets.
I would imagine it would be predetermined at negotiations before it goes, the contract goes to the POCC so that it can be itemized out.
Thank you.
Other questions, thoughts? The performance guarantees are, again, something that we compared in the executive summary, but these are dollars that we also shouldn't really budget for, that nobody wants these numbers to hit, because that means there was a disruption to somebody somewhere, employees not getting ID cards in time, not being loaded in the system. Those are all things that your team doesn't want, your employees don't want, the carriers don't want. So, but these are the fees outlined as a comparison from one to the next, and how much fees they're willing to put at stake if they have misses.
So these generally don't come into play.
No, if they do, yeah.
Maybe fish to fry at that point.
Yes. Going back to the pharmacy. So, and this is where I'm going to point out, I think earlier we talked about consistent numbers, right? Is there a consistent number we use? And I said, oh, wait, there's a place where we didn't. Let me show you where. This is where we, as a consulting firm, we can't take and manipulate the data of the responses, because what we ask them to do using a very specific set of data is tell us how they would have processed those claims. And everybody has a different reason. All of them have different algorithms in their system for doing what they did. So we're showing you as they stated. And as you can see that they're showing a different employee count and a different member count than each other. That's a different employee and member count than I had on my page, or that you would have, maybe if somebody pulled up current enrollment today, that might differ. So I wouldn't focus on that. I would focus on large dollars, net employer costs for everything all in for prescriptions. And then the per employee per month, or excuse me, the employer, per month per script average basis. We looked at this on a 1 year and a 3 year. We asked them to provide us the data on a 1 and 3 year basis. And then lastly, the network comparison, and that is, oh, go ahead.
Is there an obvious reason why the one is?
Yeah. Well, say that to me one more time. Say the question again. Is there a like when you're comparing the three of them?
Compare collection that employer costs per script. One of them, the 1 year and the 3 year just aren't even comparable.
Amount of scripts that were processed on the 3 year.
Right.
Oh, yeah.
Profit from the.
Correct.
If you're looking at their totals, I can tell you one of them did have a calculation on wrong numbers on that.
Okay. I would really not look at the employer per employer cost. Like I would focus on what's the all-in cost. Like if you're looking at, remember earlier when I said, let's look at numbers to roll up to one another where we can. ASO fee, medical claims cost, pharmacy. Those are the three that you can easily. So that line item there where it says on the 1 year summary, the net employer cost, the total claims repriced, and the ASO fee. Add those three together and that'll help you make a point assessment for cost specific to the medical plan and pharmacy pricing.
How much are we paying now in 1 year?
We don't have, I don't know if any of the technical advisors, this was not just.
This in particular, you can't compare it because again, that claim number is not a 1 year number, right?
They're turning
Was the
it
number
into
of scripts, was that just given to them or?
They were given a file of all the scripts for a certain period of time. I really wouldn't say that is, you have to make a decision based off of one of these three. So I understand why that matters, but it doesn't for the purpose of scoring. These are the new costs going forward. And it just really, it would be a complicated equation to take a 12-month period today and compare to any of this data.
Can I show you something that I discovered in calculations? So, which will put the one number way off for one of the proposals.
I got in here.
Okay. So on this pricing and fee summaries. So
can you show me which folder you're in or which person?
This.
Okay.
So when they did their calculations, they put the same 1 year number instead of translating it to 3 year numbers. So then whenever you do the calculation down here, that's what they put 303. But that's what it really would be if they had done 3 year numbers instead of 3 year claims numbers, whatever. So it makes that number really off for this one.
I think
I think it's kind of what Tom was asking, like, why is one of them drastically off?
Yeah, so let me find a way to say that back to, and now we're on the same page. So what I would encourage everybody to do, and maybe you could tell us what rows or rows those were again, is we have to rely on the written proposals, right? Knowing that we have these written responses. You can go in and
say there's an error in so-and-so's submission.
Yeah.
You can say whose submission. You don't have to mask whose submission there's an error in.
Okay.
You just can't call out numbers. So don't feel like you can't say links to an error in the 3 year calculation from what we can tell. Okay. That's your analysis. That's your evaluation of it. We're here to do an evaluation.
Okay. Yeah. I would say this too, that like if what I would focus in on is the net cost, right? Like that's just a calculation of breaking down. I feel comfortable that they reported to you an accurate annual and then 3 year cost. It's just breaking that down on a formula. So if you look at each one in the pricing, pharmacy pricing and comparison analysis, you can see why, if you're looking at these 2 pages, why the middle proposal on the proposer on the 3 year is off. And then you could, but that's only on the per employee per month piece. Like I wouldn't focus on that to make a financial decision.
On the dispensing fee on the RX pricing and fee summary, those are accurate, right? It wasn't a typo, just because the one is so much larger.
Yeah, I mean, it does match what was in there. Let me go in and look at them real quick, but it matches what was in the responses. I feel like we even peer reviewed each other there, so I confirm.
People, it should be.
Yeah, because I think we saw it too, and we're like, hey, like, let me just make sure it matches the 1 second.
That number is correct. For the room, you have to take what the written show for the room, please. The conversation has to be for the room, please.
Then just for first. What you were saying.
So
Sorry.
if you're looking at the RX pricing and fee summary, whenever they provided 1-year numbers and then 3-year numbers. So one proposer used the same employee and member numbers for both 1 and 3 years, which makes the 3-year total net employer cost per employee per month very inflated, because you only used a third of the number of people, but a much higher cost because you were paying
3 years of
worth
claims.
scripts, claims, yes. So then if you just look at the middle on page 14, the net employer cost way down at the bottom, in that bottom row, the one in the middle should actually be a third of the cost of what is listed.
And then my response was, but we have to take what was submitted. We can't correct their formulas.
We don't know if their formula is inaccurate or not.
Okay,
Fair enough.
Yeah.
but could one say that if you take the 1-year scripts and multiply it by 3, that you should come to the correct number?
Again, we have to take what is submitted on the paper.
I think what would be a better way to perform your analysis would be what is the total net cost for prescriptions and which one is better on an annual basis.
Yeah, maybe we just look at the annual number and not the 3-year number.
But I'm still trying to find that, Mike. I might have to come back to it, but
That might be the better way to.
system is not cooperating.
It looks, I mean, 3-year, it's there again. And it's a lot higher, so it looks like it's.
Yeah, I think another thing to keep in mind too, is that's a great point, is like, everybody has different levers that you can pull to save on pharmacy, and every proposer is like, what if you do this? What if you do that? Some of the things you might already be doing, or some of them you might be like, we never want to do that. But these numbers also aren't taking into account innovation, right? That could happen, and the things that you could do to help reduce cost.
I think so, and I think each of the proposers called specifically out during that presentation.
If I could just make a comment on something like this as an evaluator, that to me shows weak attention to detail. And if you read the executive summary of that specific proposer, you would see a lot of grammar errors as well, which is not good attention to detail. And that's all I'll say on that.
Again, you don't have to hide which proposers you're talking about.
I know.
For the meeting, you just can't give the specific details of numbers. So
It's,
that,
I'll say it, it's
the point is for the committee to know who you're talking about.
It's Aetna. We're speaking Aetna. And grammar errors sound silly, but that to me is just like, wait, how could you do this?
Oh, I
Sorry. Yeah, sorry, I'm not speaking loud enough, so I'm sorry.
We were questioning, Mike, I think the first one on each of the pharmacy summaries, right? Like just, yeah, because it was so much, just making sure I'm in the right. We did, I pulled it up again. Like,
But the 3-year is.
that, maybe they didn't like,
Great.
oh, I bet they just didn't multiply every.
Well, no, I mean, the 3rd year is accurate. If you take the first year, the 1 year and times it by 3, it comes out to about what the dispense fee would be on a 3-year basis. So
Yeah, that is the number that is on both of them is correct.
What was in.
Well, yeah, I mean, what you're looking at.
Correct,
here
based on the
Yes,
proposal.
it matches.
Proposal.
Oh, yeah, it matches the,
Right.
yeah.
They're
we didn't create,
manipulate
yeah.
it. Yeah.
Let's see, so network, when we're getting into the network access.
Just
Yes.
before you move on, so you have not prepared like a summary of all the costs, like ASO, credits, recalculated claims, pharmacy cost, all of that, so we can see like a total amount for each vendor.
Yeah, we can't. There's too many variables in there, but if you wanted to look at so you could take the buckets from, if you needed that.
I can do it myself.
Yeah, no, we have not.
No, we have not.
I mean, I looked at the buckets from page 8, 13 and the total cost. And if you add it together for each one of them, while they're different types of pricing for the different pharmacy and the medical, they're all within $1 million of each other.
Yeah.
Literally at 155 to 156 million.
Right. And I think hopefully it's fair to say this. I think we kind of expected that. That's why pricing is not where your pricing matters, right? It's public sector. Yeah. Yeah. Your HR team is doing an incredible job of managing costs. So it's pretty lean already, right? There's not a lot of room or no magic. Well, there's things to do and there's innovation, right? But like, we knew that was going to happen. And so I think intentionally when you're scoring this, you have to look at something bigger than pricing because it's going to all be.
But right now we are talking about pricing.
Yeah.
So that's why I'm asking.
No, that's fair.
I understand other things have higher value in the overall evaluation. Since we're talking about pricing, I'm asking for price.
I'm sorry, you were going to go on to what next?
Network access.
So does that mean we're moving to a different area? Should we
Yes,
talk about
two
pricing?
pages of the, okay, that's fair. If we want to stop and like, if you guys want to talk about pricing, just to, I think that does, if you're looking for the committee to have a scoring pricing, I think we've talked about everything we need to there.
Okay.
Want me to reiterate what's included in that criteria?
Sure.
So you guys are aware. So for your pricing and discounts criteria, the 15 points, that should be discussed, including ASO pricing breakdown, medical claims repricing questionnaire, your hospital network discounts, and your pharmacy summary and pricing table. Those are the items that encompasses. So if you want to have that discussion and possibly score.
And let me just really quickly preface to that. So when we talk about the hospital network discount, remember we said we shouldn't plan on the fees at risk. So let's focus. I'm going to draw your attention to the average discounts, which are, if you go back to page 8, when you look at aggregate medical provider discount, you can see they're all within like 0.4% of one another. So ASO fee, all the things that that Sakina mentioned, but where you're getting that network discount info is that actual percentage point. I wouldn't focus on fees at risk. It's relevant, but it's not a number that's probably going to be payable.
Does anybody have any thoughts on how we go about getting to a consensus score?
Pin and drop.
Somebody throw out a number and.
We take it maybe each, like, let's look at ASO fees, let's look at, the different areas and then maybe we can.
Would it be helpful to say, if you look at the analysis that Baldwin provided you, ASO pricing as provided here, Baldwin gave you green, yellow, and red in ASO. So if you were to start looking at scoring lines or big insert proposer here, pick one alphabetically. Okay, we're gonna go and look at that. And so if you go by each questionnaire that's in that category, ASO pricing, You see what I'm saying? And go through each of those categories and look at what's green, yellow, and red from there. And that will help you each write down some sort of configuration of numbers that get you to 0 to 15, questionnaire by questionnaire, proposer by proposer. We pick a proposer, start going through these questionnaire by questionnaire and see where you land on 0 to 15. Know that you don't have to say ABC company gets 15, which means that XYZ company can only get 14. They could all get the same score if that's where you land. So how you score, you want to look at each one individually and what they gave you. And then where the scores land, the scores land. So you don't have to grade it on a bell. Does that help too?
Yes.
Okay. So if you wanted to, an approach that you can take is to pick a proposer, a questionnaire, and then go through and look at what you have in here, if that helps.
Can we ask our advisors, especially those who are in the weeds of the finances, if there should be any hierarchy of these different categories here? Like, should ASO pricing breakdown be more important or higher ranked than pharmacy summaries and pricing tables? Is there?
ASO is
I was gonna say
2%.
It is a
Yes,
very
very
small
minor.
amount. So
Yeah, so the-
I would rank them in RX repricing, medical repricing, ASO.
And all of them might also, where is our highest amount of spend? So.
Medical.
Medical, pharmacy, ASO.
Medical pharmacy ASO.
So would it make sense? I mean, I know in a lot of other procurements, the company with best pricing gets full points. And then and if there's a
We do a
mathematical
formula.
calculation,
Yeah,
there's
we
a
do a
formula,
formula.
another one. Should we consider selecting one as, okay, this is the one that gets 15 and then go from there? Does anybody have a problem with that? So we can get set.
Sounds good.
You can do that. Some of this is
That
because
doesn't mean
it's a
that they
little
give it the
bit
best price that
subjective.
we
We couldn't apply a formula here in pricing in this situation.
Correct.
We wanted to. Paul and I tried, and Sakina, we tried, but unfortunately, because this was subjective in how it's set up, we couldn't apply a formula to your pricing points. So, but you guys can evaluate and go about it that way.
Does it sound reasonable to do it that way? Because I mean, we do it that way in others when we're doing this, it's straight math, it's a straight bid.
So,
Just taking the lowest price and giving it the highest value? Is it not priced to what you're getting for it? Or are you just looking at the dollars?
Well, I mean, I think all that factors into.
Yeah. This.
I mean, to me, we would select one of these and say, on an overall basis, we think this one has the best pricing scenario. They get 15. Okay. Who would be next?
15 to 25,
Or would it be that big a difference?
depending on how different they are.
Yeah.
Yep, and as a group, you kind of talk it through, yeah, I'm good with 15, yeah, I'm good with 12, yeah, I'm good with 10. However you want to do that, that's the point of consensus scoring, is you talk it through and everybody comes to an agreement.
Just a thought, real quick too. I think Nicole makes a great, go ahead. Sorry, keep talking for all of us.
As you're thinking about pricing, it's not specifically called out here, but where would you guys want to put these credits and financial resources? Because they need to be taken into consideration in either one or multiple buckets. So as we're talking about pricing, do you want to add an element of these into the pricing discussion? I do think it's also applicable for it to go into the understanding of the scope and objectives bucket as well. But I just want to throw that out there for consideration.
And I would think we would put that in the pricing because that fee holiday or that admin fee holiday is included in that bucket, right?
Well, where were they submitted in the proposal?
It is included in their proposal pricing. All of the proposal pricing do have financial credits.
If you look at the way that the evaluation criteria is set up, we've called out what makes up that criteria. So for pricing and discounts, the ASO pricing breakdown, the medical claims pricing questionnaire, the hospital networks discounts, and the pharmacy summaries and pricing tables are what make up that pricing bucket, or that, I'm sorry, that evaluation bucket. So the proposers were given criteria as to where to focus their proposals. So we need to make sure that when we're scoring, they put their stuff in their proposal based on the bulk of their score was coming from that 65-point bucket. So that's where they focused their attention. So if we're allotting points for something that wasn't in that bucket,
True.
we're not giving them the points in the appropriate place. So that's, and I can't honestly say in my mind where those credits were in their proposal. And I'm not sure everybody provided things in the same place all the time, to be honest.
Or in more than one place.
Yeah.
Multiple lines.
It is a hard call, and we'll do the best we can. I just want to be cognizant of that.
And I think to that point, I think it's an excellent point. We're going to look at where we asked it in the questionnaire, but yeah, and then it's also reasonable when I said, hey, it's in their financial proposal. That's a reasonable place for them to put it as well, because that's where the dollars go.
And in the evaluation criteria in section 1, where we do have the 65 points, we do say ASO questionnaire and attachments make up that 65 points. So don't feel like we split a hair and we can't look at it in both places. So you may be able to consider it in both places.
I think you can, because it is called out specifically in the wellness questionnaire.
Yeah. So the pricing of it and the
ASO, right?
The cost of it here, and then what it can be used for can be here. So you have the ability to split the baby, you know what I mean? And have it and benefit you in both places. So
do we ask for the fee holiday or the extra money on the ASO pricing page? Okay.
The breakdown? Yeah.
Oh, in the pricing?
Yeah,
pricing.
In the breakdown page, we had it.
Yeah.
Are we talking about the questionnaires or like?
No doubt in Mindy's answer.
Yeah, I know. I feel comfortable with that.
That woman looked at the numbers.
Okay.
But I think there was a question in the ASO, which I think they had that up, about, what they would provide.
Right.
And all of the proposers basically are saying, here's a bulk of money.
Right.
Well, and that's it. So
They're not actually applying it
anywhere. My question was pointing towards, if we didn't ask it on the ASO pricing page, then maybe we should not consider it in the ASO pricing points. That's where I was trying to
We
figure
asked for
out.
the holiday on the pricing page, right? The breakdown. And then we also asked for anything else, which one of these things are included in your ASO? And a lot of what they did, they say, okay, this is the lump sum, right? So it really is in both. So like to Chrissy's point, I think it could be considered in both areas. And we should be good with that.
So like that advisement.
Area it references the ASO questionnaire and attachments. In your pricing and discounts, it specifically talks to the ASO pricing breakdown, which was that document they provided, that spread or that Excel file or whatever.
Thank you.
And then there's comments included in that I think delved into the other pieces. So I think you're covered in both to that point. So now go forth and create numbers.
Would there be any benefit in, this may be unusual, I don't know, and we may say, forget it, don't do that. There's six of us?
7.
7, to say, have everybody write down how they would rank 1, 2, and 3. And then have a discussion about what the score should be for each of those. And then if we could come to consensus on 1, 2, and 3.
Generally, we have around, but I will tell you typically what we've seen.
I don't want anybody to feel like they're pressured to
Right.
rank in a certain way.
Well, and generally what we've seen is evaluation committees, they'll go around the table. Oh, I gave them 10, I gave them 12. Here's why I think that, you're here to give an opinion. Sorry, pressure to be had. And everybody gives their opinion as to why, and then the discussion is had, and some people have to come down and some people have to come up. And then you come to a number.
I just don't want anybody to feel pressure like they're getting forced and.
Yeah,
Like, we don't want to
And
be.
and that's fair. You could just come right out and be ready to say, okay, so proposer ABC. I would have scored them in this category here.
yeah.
What's everybody else think? And everybody can, say what they would have scored and just come to a consensus and just go through that way, each proposer.
Yeah, and usually we go by proposer, not by category, if that's helpful too, because then you're not comparing your scoring a proposer's proposal, scoring a proposer's proposal, scoring a proposer's proposal, and then the totals are what they are in the end. Because keep in mind, this is not necessarily a comparison of each other. It's scoring them based on how they met the evaluation criteria. And then the scores fall where they fall. So it's not necessarily a rank this one, 1, 2, and 3.
So is it a fear of speaking up?
Somebody wants to throw something out.
Do we have an unredacted version of this one?
What is it?
That wasn't part of our analysis. That is in everybody's responses.
I think that was.
What is that?
Is that what's up from
Sigma?
That was
That part of their,
so Cigna's proposal had their unredacted information behind their exemption letter. Their exemption letter was 100 and something pages long with their unredacted information behind it.
280 to be exact.
Okay, Cheryl, you want to go first?
Oh, me. All right, I'll just start speaking.
I the whole thing by proposer or just this category?
I say this category because this is very complicated.
So we're
I think the loose
clear. I
side.
think I might have it up already.
Okay, so I'm going to look at Cigna first because they're the ones on the left. So I read left to right. I am looking at ASO fees and I'm looking at the medical and the pharmacy repricing. I would say that their ASO fees and what they're offering would be number one. However, the medical and the pharmacy repricing are higher than the other two. So I would recommend, I would say I would bring that 15 points down a smidge from a smidge. Is that an actual measurement? From the 15 points because of that repricing. Although the repricing mentioned, thank you for saying that. So I would say 13
For Cigna.
for Cigna.
And what about the other two?
Oh, okay. Aetna. Okay, that's fine. We can talk all three. I do have some concerns about Aetna's 5%. Oh, am I allowed to say that?
Yeah, be careful with numbers.
Okay, about the annual max cap renewal percentage. I found that to be the highest of all three. And so that caused me concern, especially when you're looking at the length of that contract and looking at the percentage and adding up how many years, how much percentage that would actually go up over the length of the contract. Okay, then let's see. Also, their ASO fee was the highest of all three proposers. So on the PEPF.
So just to share really quickly what we were doing, there are, he was looking for some information that was specifically exempt. We're just writing that down for him, is what we're happening over here. Sorry.
Because Tim, you need us to help you find it in the files.
That's
We
okay.
can also, okay,
That's fine. It was 3 numbers.
got it.
We're bringing it over. We're going to,
Yeah, we're just. Then United Healthcare, although they're marked in yellow, you can see that the ASO fee is just a little lower than Aetna's is. So I would rank, just for ASO, I would rank Cigna, United Healthcare, Aetna for ASO. And so maybe 13, 11, 10, because I think United Healthcare and Aetna are very, very close. And the repricing is just too similar to even try and figure out. That's my pain point right there, is including that repricing in there because it's so close. How do you do that? All right, so I spoke first.
I'm sorry, you said Cigna 13.
13, 11, and 10.
United 11.
I'm sorry, you said
Tear it
Aetna
up.
10?
I'm sorry?
You said Aetna 10 and United 11?
Yes. And my reasonings are the high ASO fee, highest renewal rate, giving them the lowest score on the pricing.
And I think it's probably important to point out, but if you looked at, United has broken out their administrative service fee in two different buckets, right? There is the medical only, and then there's the pharmacy per employee per month. So when you look at just the medical only, it looks a lot more in line with, it would be ranked second if it wasn't, but when you add that additional per employee per month fee for the RX, then it puts it back at, well, it's still second, but this is hard to do without numbers. Keep in mind that if you're looking at just the medical only PEPM, you need to add for United Healthcare, you need to add an additional pharmacy PEPM for when you're looking at the proposals. And that is truly to administer, and that's how Cheryl's getting her ranking in the order of it.
Now it's somebody else's turn.
And where I can show you what I'm talking about, or where I'm coming from, is if you go back to our presentation from today, pages 7, 8, and 9. If you look all the way to the right, the proposer on the right. Yeah, on the right. Okay. I was like, wait, literally, sorry, you're on the right. Excuse me. We're looking at the number in blue for administration. That's the very first number. And then about halfway down the page, you see another number in blue. You need to add those two together. And then you need to compare them to the number at the top for the middle proposer and the number at the top for and we've done that when we did that annual calculation for you. So when Cheryl ranked them, that's what we've done. Oh, sorry. I'm just kidding. That's not exempt from public disclosure.
No. I was just the bold one to go first.
So I would put Cigna at 14, Aetna and United at 13. And the reasoning being is because of the rate guarantee.
Good point.
They're giving more in funds. And then I'm deducting the point because of capitation for Cigna. The other two, their rate guarantee is not as long. Their fees are higher, but when you add capitation, it kind of balances out.
You mentioned numbers for Cigna and United.
Actual numbers?
No,
ranking.
Oh, I'm getting 14 for Cigna, 13 and 13 for Aetna. Yeah, okay.
I'm still having a hard time mathing out the ASO fee for one of them. Where it doesn't seem to work itself out when you're taking their monthly cost, multiplying it by 12 to get their annual cost. I could figure out the reductions in the other two. But one of them is much more difficult to figure out.
Which one? So maybe.
Cigna's more difficult to figure out.
So let me say this, that amount that they're putting in there, they're also including that 5% minority funds.
Just in the Cigna one?
Yeah. I'm sorry.
Numbers.
I'm sorry? I didn't say number. I didn't say numbers. I said the 5%. Hold on. That's public record because I'm sorry, and it's actually 10%. I meant 10% of the funds that they are saying that they will spend. That's what's in there to get the 5 points. That's what I meant. They're including.
Oh, I see what you
Yeah,
mean.
yeah, that's what I
Gotcha.
meant. I didn't mean numbers. I meant the 5 points, so
The percent.
that
they're
is
giving.
throwing that number off. And if that makes sense, it's not, but I think, Becky, maybe you could give guidance on this.
I'm not following you. So let's go back to Tim.
The two,
Tim, ask your question again.
So with two of the proposals, I can take their ASO monthly cost, multiply it by 12, and it gives me a larger number than what their annual cost is. For the other two, I can figure out where that money came from because it has to do with the 3-month holiday. It's equal to that.
Can I look over your shoulder for a second? Because I just want to make sure I understand, like, if you're taking,
Let me look at the.
are we talking about this number here times the number of people? Okay, so
Their monthly ASO cost is times 12 gives you an annual, right? Comes out to this. The difference here and there is exactly their 3-month holiday.
okay, I see what you're saying. So he's looking at a different document than us and what?
Oh.
In this one, it doesn't get discounted by that.
Yeah, okay, well, so here's, and you do have to go with what's in there, but so there's one of the proposers in their ASO summary, like in the responses, they're taking a fee holiday from their thing, but the fee holiday is also included in the bucket, so it shouldn't be taken out there. You should really just, because that's also coming out of your bucket of.
So it should be this number.
Yeah.
Which
Yeah.
then adjusts this number.
That number is correct.
1.9 is correct.
Yes, 1.9.
No
numbers. I didn't say who.
When you're addressing the fee holiday for that, they do indicate in the proposal how many months of that holiday they're gonna give.
And 2 of them did that, 1 did not.
Yeah.
One of them didn't have a holiday, right, per se? And the other 2 did say how much it would be.
one of them said it was a one-time.
Yeah. One doesn't even have a holiday. Like, so if you look at pages 7, 8, and 9 on our thing, if you go into how we broke out when the admin fee is waived. But again, and this just proves my point to the one we were just looking at, you see how I have it highlighted in green? It's because it's deducted. Oh, sorry. I know we're moving around like that. I have it highlighted in green because while it is a 3-month that they're proposing, it also is deducted from the bucket of financial resources. So it should be evaluated after the ASO. I think we're saying the same thing, right, Wendy? Okay.
I actually have a question. On the executive summary, the first page for United Healthcare under credits and financial resources, the first bullet has a number there, but there's no delineation of the 100,000, millions, whatever. Can you just clarify?
Okay, after that.
Thank you.
Thank you. Yeah.
M, no.
I figured M was that from the record. It was good.
Then one other additional request for a refresher. For capitated claims, there's a, describes what they are. What does SA stand for?
Substance abuse. So behavioral health, substance abuse. Yeah. That was, you were supposed to call me out, my person over there.
Deep in thought.
Yeah.
I would say I have given a score based on many of the same things that have already been brought up and discussed, so I won't repeat all of those, but I will say I have given Cigna a score of 14, United Healthcare a score of 12, and Aetna a score of 11.
Based on what?
Like just the different nuances in pricing between some have more of this discount, hospital discounts, some have less. The total ASO fees, the pharmacy summaries, there's some similarities, but again, there are some other aspects kind of taken into account. So, but they all seem very similar in their medical claims repricing. But again, when you take all of the things that the Baldwin Group has taken into consideration and roll it up into that one piece. I know for the one you were asking about, the number not, in your mind, not adding up, in one place, I saw it actually written for that fee holiday or whatever, credit assumed included in the bucket, yeah, in the credit financial resources. So that might kind of help to understand why the numbers look different in the total calculations.
So the medical claims repricing is the same, right, for all of them? That's not really a factor. Hospital network discounts are similar. Not really a factor. That really comes down to just ASO pricing and pharmacy summary. I think Aetna has a clear difference in pharmacy product because they're related to CVS. Is that?
I think that that is fair to say based off of what they told us yesterday. I would also say that you got to look at how many claims they're processing and how many members they're allowing. Like, I think we're just looking at that piece of paper. You can't just assume the coalition is what got to that number.
They said you could go to any pharmacy.
Yeah, but they're saying that they have that, like, so I think he mentioned the coalition specifically is, so they did say that yesterday, and I'm certain it has an impact on their pricing. I don't think that's the only reason you're looking at why that number is low, different there. It's a different number of scripts. It's a different number, you know, there's a variety of factors there.
We're getting into the employer's costs. Is there any experience for the employees differences? That wasn't.
That's part of this.
Yeah.
Yep.
Not when it comes to, go ahead. Yeah.
That will come in plan design.
Yeah. And I was just going to say specific to cost. So like when we talk about the network, all of them are everybody, there's no like outlier here. We're like, oh my gosh, one doesn't have CVS or one doesn't have Walgreens. Like they're
on pharmacy pricing, we can see significant difference between net employer costs in all three of them. Right. And you can just multiply that over the 3 years to get
the times 3. Yeah.
I think I'm ready to go ahead and give. For me, Cigna came in highest with, I would say, 13 points. What I liked, kind of as others have said, you know, the rate guarantee, the cap that's in there, the annual ASO cost, kind of like what stands out to me from another perspective would be that, you know, there's capitated claims in here. It's not exactly clear, at least on the summary itself, what the long-term costs are, how that factors into everything else. I don't like the lack of transparency. And I think the other thing is the cost on the pharmacy, you know, ingredients. I mean, there's a significant difference from them to the other providers. Next would be United Healthcare. I would score them at 12. They're kind of in the middle of the pack where it goes for the ASO fees. You know, the rest, the pharmacies seems fairly competitive. For me, Aetna was coming in at 11. They are the highest as far as ASO fee goes, and their rate cap is the highest as well. I think the other thing that stands out for all three of them, why nobody's getting a perfect score from me, is that there's discrepancies between what's in our written proposals and what was said to us yesterday. So we can't really rely on what was said to us yesterday or take that into account. We have to take into account what's in front of us. So, try to weigh all that and take that into account. Oh, we can do this. No, we can't do that. Especially when it comes to some specific offerings, we're looking for, all of them received a little bit of a markdown for that.
It's what we're here for. Really hard time with this one. So for the items that are not included in the ASL, and I guess there's some on each proposal. How do those get valued? Is there any document that has evaluation of what that's costing?
So
all of them have something that's not in the ASL.
they do, but also if you go into that folder and in the responses, they all also tie back to, there's things that are placed in multiple, I'm trying to think of how to answer this. There are, the ASO is in their fee disclosure is in that same bucket as well. So things not included in ASO proposal. If you go into at least how we were, our categorization is similar to how you guys had it. There is a full proposal in there. So you can assume that all of those things, and then you just need to read, is that included in, like, if you look at each of their financial fee proposals in there, you will see a line item for things that are included and things that are not included. And we tried to summarize that for you as best we could for the areas that we think you have to score on. I'm not sure I answered your question other than to say that everything is in both of those folders. Maybe that was a much less complicated way to say that.
But not boiled down to compare.
No.
Kim, to your point, it's not apples to apple because some of them do include some things and others don't, right? And they include different things. So that's where I'll look at the whole thing.
So Tim, it might be helpful to just parse out the two separately and just look at ASO as it is ASO times 12 months. And then you have a figure and then what they're willing to provide back to the county that could be applied to the ASO. So I would suggest you keep it separate.
We're down to Irma, Tom, and Tim. Yes. Yes.
For Cigna 14, United 13. Well,
I mean, at least it seems like we have a pattern. I can go next. I score Cigna at 13, United Healthcare at 12, Aetna at 11.
I'd be willing to come up to 14 for Cigna to make that more of a consensus score.
You want to present that to the committee as your suggested consensus score, and the committee can decide if that suits them. Oh, sorry.
Oh, you're waiting for me.
Yes.
No pressure.
Yeah, no. I think on the pharmacy Aetna's ahead easily by the amount of cost. I think 7 million. Sorry. The differences are significant, especially over time. I think that has value to it. And then the ASO pricing, I'm having a really hard time with the extra fees and things like that in the Cigna proposal and understanding exactly how that money comes out. However, that influences the score. Actual numbers. All right. I will do 14 Aetna, 10 Cigna, 5 United.
So committee, we need you to agree on a number for each.
Do the math, everything.
No, we're each.
Let me do an average.
Take an average.
What is the average? If you add them all, what's coming up to?
Are we allowed to comment?
You are, yes.
So, okay, so, when you're considering your score, did you consider the rate max cap of each of those?
I did not.
So
That is significant in the end.
it is significant in the Aetna,
You're right.
yeah. I just was asking.
After the third year, it's 5% every year. Common. Sorry.
It's okay.
It's a large amount, which presumably compounds, and that's max. That's a max. It's not a set number, depending on experience and what's reasonable. Is that negotiated at the HR level after the third year? Depending on experience and everything else. So no, I did not consider that.
So there were, right, so we have Cigna, we have 4 scores at 14, 2 scores at 13, and 1 score at 10.
Mhm.
Is there a consensus we can get to on that?
I will raise my 13 to a 14.
That was,
Yes, you included that? Okay, thank you.
The average number.
13.1.
13's a round number.
I would be willing to lower mine to 13 if that gets us to.
Same here.
Okay, I'll go back down.
We were doing that. You missed that. What are we?
Maybe we shouldn't go with averages, because I mean, if we have
Okay.
that, I thought that was a good idea, and I don't think it is anymore.
I don't either. When I was doing the math, I wasn't sure I agreed with that calculate, but, all right, so what did we just agree to score wise?
I think for the time being, we agreed to 13
Or
for Cigna. And we have,
before we do that, does the committee agree to that score for Cigna?
Yes.
for now, right?
Yes.
So that's what we end up doing too. So now we had 110, 3 11s, 112, 113, and 114. Seven.
I'd be willing to come up to 11.
I scored them at 11.
Scored at 11 as well.
11. United, we have
11.
What did you consensus on for Aetna?
11.
11.
11, and the committee agrees?
Yes.
Yes.
for United, we've got 1 5, 3 12s, 2 13s, and 1 11. 11.1.
You can't have the same score?
You can't,
Oh.
and it does not.
Well, it's not up to me, it's a consensus, so. But I would say 1, 2, 3, 4, 5 of the 7 of us rated United higher than Aetna.
Agreed. I think there's one score that brings it down. Yes.
Put out a number or?
Would 12 be a reasonable?
12, I'm going with 12.
I rated him 12, yeah. I do.
Follow the group. You're good with that, Jensen? I mean, you're the one that was.
Different.
I was trying to create separation.
I give her.
I guess,
Not
well, I
want
guess.
to make you feel stronger on making a decision.
No, no, exactly.
I have my HR rep.
That's the point.
Okay,
So 12.
Okay.
13, 12, 11.
Okay. All right.
Everybody's good with that.
So that is your category 3, your pricing and discounts, scoring. You still have your, category 1, 2, and 3 up here. I don't know which one you want to go to next, but it's up to the
We have
committee.
5 days to go.
If you want to take the rest of these buckets and read just one proposer at a time, if you do the rest of the buckets all at once, it's up to you.
Well, let me ask you, what about like, do you have feedback on quality and experience? That's a 5-pointer.
Yeah.
Go ahead, you first. I missed the question. I was trying to do some math.
So I will say the 5
Qualifications and experience.
bucket that you have for proposers, organization qualifications and experience, that would potentially fall into the references, et cetera, that were done. We deferred that to Becky. So I'm going to give the floor to Becky so that she can let you know what she did in her analysis and what she found for references.
So I have copies. I don't know if anybody wants paper or
I
not.
don't have enough.
Oh.
Just,
Okay, Becky.
We got it. Well, that way. Quick.
Okay. There we go. You don't even have to stand up.
Maybe we all need to stand up to get
Some of you might need to, advisors need to share or whatever. This is very, very quick, okay? I reached out to all 15 of the references.
Yeah, I got 2.
Yeah, there could be some more.
You need any more, Cheryl, down there?
Oh, no, we have 2 right here.
In the executive summary of the RFP responses, each of the companies were asked to provide 5 references that are of like size and to provide, that have been in force for longer than 1 year. We got 15, or we got the 5 per proposer. And I reached out to them with a survey, an online survey. And the key points that we talked about were implementation, or that I had questions on, were implementation, contract compliance, customer service, and wellness initiatives. And it all boils down to 7 responses back. I got 3 that were bounced back for nobody at that location. So it was either a bad email address or it was that person no longer works for the organization. But I did get at least 2 per vendor. So that's good, 2 per proposer. And I have to say, number 1, they meet the experience and the qualifications in the RFP based on their size and their years in practice, I guess we'd say, in business. And then amongst all of the 4 categories, they all were rated very highly, either exceptional or outstanding. So in that particular organization, qualifications and experience, they all did very, very well.
The other piece that we do want to bring up here that is part of the requests was the AM's best ratings, which I believe Goldman Group was going to provide. Do you have that?
They're all A-rated.
They all did qualify.
Yes.
They are all licensed, so they can meet that qualification, et cetera.
I was hoping this was gonna be an easy thing.
I'm willing to give all three of them a 5.
That's where I.
Second, third.
I agree. Can I ask one other question? So do, like, their certificates of insurance fall into this category?
As in their COIs in
Meeting the minimums, is that something that happens at negotiation if some of aspect is not listed?
we do not require them to submit their certificate of insurance. If they did, they did. If they didn't, they didn't. It's up on county requests.
Okay.
So if it's not in there, it's because they didn't upload it yet, and we would ask for it after with the firm that we anticipate awarding to.
Okay.
So if you were concerned because it was missing. it's
No,
because
they were all there, just some of the aspects did not meet the minimums that were listed as
We would make
required.
them fix that in order to meet our minimum requirements
Okay.
before we could proceed to
Okay,
contract.
then I would be happy with giving each of them a score of 5 in this category also.
Sounds like we have
Got
a
a final.
consensus score of 5 from the committee on all 3 proposers for that category, correct?
Yeah. Now it is 3:00. Does everybody want to take a 5 or 10 minute bathroom break? And yeah, 5 minutes, 10 minutes. What do you want?
10.
10? Okay. It is 2:52. We will be back here at the 3.
We're going to keep the recording going, but I will go ahead and put it on mute since we are on a break. But just for those online to let you know that we are going to put a mute on for the moment. Yep. So we'll be back. All right. Okay, so we are back off of mute. We are back from a quick break, and we will go ahead and let the committee continue to go through their process. It's up to you on whether you want to do category 1 or 2, but you do have those last 2 categories to go. The heavy point category is the category 1, proposers' understanding of scope and objectives. That has the major questionnaires in there, and then your category 2 was the quality of the proposed system and ability to achieve the objectives, which is your reporting, integration, and implementation plan for 15 points. So it's up to you guys which ones you want to move to next.
I would suggest that the reporting and implementation might be an easier bucket to tackle. So if you want to save the hardest for last, that's just the thought.
Okay.
So what incorporates that bucket is your reporting and your integration integration questionnaire and attachments, and then the attachment ASO 5 and the implementation plan.
Attachment ASO 5 was the implementation plan.
So does Baldwin have any feedback before the committee starts talking?
Would it also include the sample reports provided?
Yes, that's
Yes,
all.
you say that, okay, okay, and attachment, okay.
To the questionnaire, yes.
Procurement has some feedback as well, so.
Do you want to give the feedback?
Sure.
Okay.
It was noted, some caught it, not everybody caught it. There is a missing implementation plan. United uploaded a document that was not an implementation plan. They accidentally, it appears, uploaded a different attachment twice. So there is that issue. You have a hole in this category for them when scoring. You do not have information to be able to score them accordingly.
Attention to detail.
So that is a problem for being able to score them. Okay, so if you have any questions about that, let us know. But we did note that when we were reviewing the documentation. It's an error. Unfortunate. Okay.
So we have just some bullets, and I think that I would ask probably your technical experts to weigh in here. The people, admittedly, on the consulting side, we are very hands-on from a financial and strategic perspective. Our value proposition really isn't part of the day-to-day administration of a plan. And so while we know all of these proposers can administer this plan for you effectively, we're definitely not going to be the subject matter experts on what the county's day-to-day needs are from operating the plan administration. And that's really where implementation and where reporting capabilities fall into. So a couple of things that we'll call out, like in the reporting and integration questionnaire, there was a question about prior authorization approval and denial rates by drug. So saying like, hey, if you're going to require a prior authorization approval and then it's approved or denied, will you provide us a report with the ability, to audit what you're doing? And Aetna cannot provide that to you. The other responders said yes. Another question you guys had was, will the proposer agree to provide weekly reporting of all claims in an Excel format by agency? So yes or no? I'm sorry, am I not supposed to say that out loud?
No.
Oh, okay.
I was pointing to my notes like, yes.
These are for close up, so I thought you were saying shoot. I'm like, oh no, what did I do? Again, that's okay. So it's very important for you guys you look at your entire budget, but then obviously you need things broken out by agency. Aetna was a no on that. The other responders were yes. Will you provide reports and assist with the, what is that a type on that? Read it. Well, I don't know that one. Achievement process?
What was that in?
Yeah, I'm not familiar with that term. ESC CHEATMENT process?
I actually had a question about that. Like, what is the importance of that, to our process?
I think that would be a Vinnie question.
Yeah.
Disbursement is when, cash, checks are not cashed in a certain amount of time, then we have to turn it over to the state. Right? So it's a matter, would they help with, that whole process? There's a whole, where you can't just void a check, right? You have to determine if that person's still available, how to find the contact information, send out letters. Currently, our county finance does that, right? And if they were gonna help with that, we would do the due diligence on making sure that we're following the law on that part of it. So with the evaluation, you'll see different ones said they would do different things. I think one of them said they would do the full from beginning to end. The other one will do limited, is kind of what we have right now.
Okay.
So now it's something I was asked to see if they would help with that process.
And that answers my second question. What do we have right now? So is it,
Ours is limited, where the county finance helps us right now in terms of, we'll get, say, okay, these are all the outstanding checks, and then we have to try to get the contact information, and then reach out to them to say that, hey, is this check still due to you? Is it still, something that we should issue, or should we, we can't get in touch with them, so then now we let county finance know that this needs to be turned over to the state.
That answered my question. Thank you. And Bindi, did you say which proposer said that they could not assist with that process?
They all can.
They just had a different description of.
Yeah.
Right, each one of them has different levels of what they will be doing.
Okay, that was the question before of what they do. Okay.
Okay, so do we feel good about that one? The next question, sorry, Becky, okay, no, good, okay. Are there any data restrictions or limitations that could have a negative impact on downstream applications? Signal was a yes, Aetna and UHC were both no's. So I think maybe I would rely on maybe some of our technical advisors to expand on the purpose of that question. And
yeah, I'll give that question some reference. So when we build an integration file, there's a lot of data that passes downstream, demographics, when does coverage start for our employees and the dependents, when does it end, and different systems for our vendors can have different requirements that they can and cannot accept. So for example, we tend to enter, occasionally we enter future dated terms. Like, somebody's leaving, we enter that in, we have a separation that's out there pending time. Or we have qualifying likelihood, let me back that up. Somebody gets married, their old coverage is ending, their new coverage is starting. Can they accept a stop date that's in the future, knowing that there's a future coverage change happening? So there may be different requirements as to whether they can accept future dated terms, or how they can accept termination dates, or even their downstream systems. Like if we're sending over an enrollment file, but maybe that feeds something for eligibility on their side, something for pharmacy, something for the providers. There may be other limitations those systems have. It helps us to know upfront what we need to be prepared for, or things that we need to keep in mind. It's not necessarily ruling them out. It actually would encourage people to say, yeah, we do have some of these limitations. So I would rather have the honesty and just see the pass-through. It's not necessarily something I'm would score down on. It's just something that helps us know in advance. Do we have more things that we need to worry about? Do we need to change our process? Is there more work potentially for the benefits team? So.
Thank you. That makes perfect sense.
Yeah. Do you provide seated discrepancy reports, logs, and notifications? Signet, oh, go ahead, sorry.
Okay, go ahead.
I'm sorry, were we ready to?
Yeah, no, I was going to say
Please tell us, yes.
So the reason that's important is when on a weekly basis, we pass an enrollment file to a medical provider. If there is currently, we have a discrepancy system where they spit back to us and say, hey, these are the people that either failed to load, or these are the people that there's some kind of change. We don't know if it's valid or not, but there's some kind of change from last week to this week. And that helps us give us a check and balance to make sure that everybody's enrolled, our systems are in alignment, and there's no gap in coverage for our employees when they go to their providers, or maybe they have a surgery coming up. So it's a very critical check and balance for the system.
Okay, and then to that point, Cigna is a yes, Aetna is a yes, United Healthcare is a no. They will not provide the seated
And that's what
discrepancy
you
report.
had pointed out yesterday, right?
Yes, that's, and not only is there a no, but there's no even additional comment of, hey, we can work with you, or hey, we can, it's a flat out no.
I noticed that too.
They don't provide a discrepancy
I
report.
don't feel like they do provide, but again, going by what they responded.
Exactly, we have to go by what they responded, not with, you know.
That's a very common thing, not even just for public entity, right? Like if there's any sort of technology file feed between data exchange.
And especially with how fast technology flows downstream, you know, from county out to our vendors. I mean, if something goes down erroneously, it's going to pass downstream and that could have major implications.
Definitely.
So you're saying that that one is a really big deal?
That's a big deal.
Okay.
That's a big deal.
Is there a threshold on number of changes permitted to one file? Cigna is a no, there's no threshold, so you can change as much as you want. Aetna and UHC are both saying yes. And they do have some commentary there, but they do have a threshold for the percentage of changes you can make to a file. So I think that would be, how big of a deal is that for you?
And the framework for that question is there are times of the year, like now, we're passing open enrollment files. There's going to be a lot of change. There's other times of the year where, you know, we have several hundred or thousand changes. That's a big old red flag. So again, it's not necessarily a yes or no, wouldn't necessarily disqualify or be weighted out. It's just something we need to keep in mind and know up front that no, there's, you know, no threshold there. And we have to make sure that we're also monitoring it as it goes through. Or that there's discrepancy reports that can help us see that, you know, we have a problem here quickly. Or alternatively, you know, if they do have a threshold cap, can they work with us on what that cap is? Can it be modified at certain times of year? Different things we can take into account.
How will a vendor interface with data downstream? How will vendors interface data downstream to the vendor? So remember earlier, one of them said they don't participate in the downstream. But Cigna and Aetna both describe how they're going to do that. But I'll leave that to you again to talk to us about the importance of any of that. All of it's important.
Yeah, and again, the downstream, when we ask the question, again, you know, we have the receiving system that we're sending the file to, and if they disperse it, if providers have their own that they reference, pharmacy has their own that they reference, it helps us to know that, yeah, this is passing downstream so that if we have major impact and we know something's going to go wrong, maybe we can stop the downstream load or notify in time. Just, again, helpful information, not necessarily a deal breaker in and of itself. The one thing I did want to take note of, believe it was on Aetna's, they replied, we are able to support multiple downstream data feeds. The question was really, what do you currently have in place? Not can you support if we have multiple, what do you kind of have in place? So it answered, but it's not an answer that totally aligns with the question. Aetna.
I would say that, okay, so the next question, will you provide data to outsourced subcontracted vendors? Cigna was a yes. Aetna was a yes. UHC says not applicable. I think that's that's what they're saying, but that absolutely could be applicable to your organization to need them to provide information to an outsourced or subcontracted vendor. So that feels a little incomplete.
And the reason that question's on there is, for example, maybe they could pass down if somebody's terminating necessary COBRA information, or, are there additional things to do over the next several years to help the county as an organization?
Well, that's it. Those are the major differences that we identified in that tab.
I have a question for Bindi and for Donna, because I think your two groups are the ones that use the reporting the most. Was there anything that you saw in those responses in the questionnaire that really stood out to you as, ooh, this is not good? Or was everybody pretty even across the board?
Go ahead. Do you want to go first, Bindi, or do you want to?
Sure. So like from the reporting standpoint, pretty much they all look like they could provide what we need. One of the things that did stick out was that one of them said they would provide like daily reporting as opposed to weekly, which will, I guess, increase the workload in terms of how often we do that transfer. And so that was the one piece that kind of stood out. The other piece was that in one of the comments, they wrote that they, in providing reporting, it would be like their bank account as opposed to our bank account and writing checks off of only for us. So you could have a check that is, one check that might have a claim from our group as well as another group, which would be an issue with reconciling and stuff, the way that we process things right now. And, we do require that it be our bank account. I mean, I think the way that they put it out there, it was that it was a combined account. Yeah, so that was of concern.
Can you share which organizations?
It's not trade secret. No.
Yeah.
Yeah.
I want to say with United Health.
Thank you.
Yes, United Health Care was the one that said they would have one check, and it could be for multiple providers. And if you look at the comment under the seeking check process, that's where it kind of was outlined on there.
I do have a question for advisors when it comes to claim detail reporting. How frequently are we receiving that now? Is that annual, monthly? How often?
We get claims reports. Not only can we fold them, but we get them on a weekly basis, right?
Okay, weekly. It's every week.
Yeah.
Okay, so I did hear that right. Okay.
Yeah, we transfer funds every week.
The volume is pretty great. So we don't want to look at 4 times as much once a month.
Right, or we don't want to do it on the opposite and do it every day either. Right.
Right. Well, the reason I was asking was that there was a question in here, I have to go to which row exactly, that was talking about the monthly claim detail. And I believe it is Aetna responded that they could provide it. I think it was, lost my place, one moment. I think it was monthly within 10 days of the reporting period. I think Cigna was saying monthly, but can be refreshed as frequently as HC desires. So it sounds like we wanted to stay on a weekly, like we're accustomed to, we have the flexibility. UHC mentions a health plan performance review. And again, with the items in there, I would have to rely on technical advisors if this is kind of equivalent to the monthly claim or not, but that process is only done annually. So
yeah, that's something completely different.
Yeah.
And I think we asked the question about annual reviews or periodic reviews of the whole plan. So I think they answered the question about reporting based on just the annual review.
Just to clarify, the reporting and integration questionnaires were not marked as exempt. So you're free to move about the country.
that's nice.
Don't have to go back to silent mode.
Yeah, it's better over here.
I've got the document pulled up.
One concern I had, they clarified, but we had asked if they provide data to outsource their subcontract vendors. And we asked about our health intelligence platform. It just says not applicable under United Healthcare. They just said yes. So, but they clarified it in the meeting yesterday.
They definitely work with all of the major, they work with Cedar Gate. I believe they work with.
Just put that out.
Yeah, I think they maybe just, yeah, agreed. Well, and I would take it, it's bigger than your health intelligence, right? Like it's the outsourcing of your COBRA and retiree. Now, they provide COBRA billing services in there. I'm not sure if they can administer retirees to that level. Like you may still have to continue to work with other outsourced vendors. And I would hate to, for the next 10 years, for you to be limited in what you were outsourcing as well with third-party vendors. So that's certainly important.
From an integration perspective, our file feed there's a, we've discussed the discrepancy piece a couple of times now, so I think that's relatively clear to everybody. The other thing that stood out to me is that when it comes to like an assigned EDS specialist, it's a person on the receiving end that's going to go through the file and communicate with us and work with us on repairing errors and issues. For Aetna and Cigna, it looks like we will have an assigned EDI specialist based on the information, the proposals and showing up in the presentations. For United Healthcare, it looks like more of a team approach where we'll be, emailing a generic team, and we might have a different person or, on the time and on the team responding. So again, pros and cons of each, but just an FYI. I will say that overall in their responses, Cigna and Aetna were more thorough. Cigna in particular, they took a lot of time to try to outline like what the discrepancies are, how their data feeds in, their response time. United Healthcare did a good job outlining their SLAs in terms of responding to issues. It's very clear what their timelines are. The other two are not as clear on those timelines, but
what's an SLA?
Service level agreement, meaning what they're committing to in terms of answering a question. Oh, sorry. I wasn't looking. But that helps us to know, like, if we have an issue, how much, it may take 48 hours or 24 hours for somebody to guarantee some kind of response back to us. And UHG's response, they did more clearly outline, how they handle different levels of issues. So something is very urgent, they're saying like a system critical issue, it's a 4-hour response. If it's a standard reported issue, it might take them 5 days. So just bear in mind.
They had a chance to ask all the questions they wanted on this one.
I know one does not have an actual implementation plan, but the other two that do have an implementation plan, could the advisors give us any information about if the timelines that they've set out are acceptable, workable within
Absolutely.
what we need done? Okay.
Yeah.
So,
Yeah,
they were
there
very
one
detailed.
implementation plan that has more very detailed and information.
On Aetna's, they had inserted some documents. Did anybody else run into any trouble opening up the inserted PDFs that were inside the PDF? They didn't open for me either. So Aetna did submit information, but we couldn't see like the additional supplemental things that they put in the PDF. So just a heads up if anybody else caught that.
I assume that was the screenshot that they were showing. What I thought it probably was, because we have to Excel that.
I think there was an area when we go, and I might be jumping ahead a little bit, but I think this is also in this scoring piece was the sample reports. And yesterday you had called out there was somebody that was missing a sample report as well.
Aetna specifically for the discrepancy reporting, Cigna uploaded a sample discrepancy report. Aetna references it, but they did not include it in their sample reporting exhibit RI or R1. Sorry.
Okay. Sorry, sir.
And I think on Aetna's, the two documents that are, it looks like a PDF that's embedded, but the documents seem to be what's following. Because it says the plan is updated throughout the implementation and distributed to all implementation team members. And then it says that there's a Gantt chart. So those are the two things. And one is following its key events with all the dates and timelines and who's assigned. And then the one following that is an actual Gantt chart.
Yeah.
So I think it's really there. Just
not readable.
Yeah.
The only other thing I noticed, and again, this is a question for the technical advisors. I know how everybody, all the agencies that are within Oracle that we're doing the payroll for, I know how we're reporting on the file feed. Is anybody currently using Excel as a method of upload to Cigna?
For the outside agencies?
Yeah.
Oh,
That are on the
I
plan.
would imagine
It's all
so.
done.
It's all-
No, well, yeah, yeah, because Clerk would be Oracle.
The clerk is Oracle.
Yeah, so.
It'd be more like, what is the children's board doing? What
Yeah,
is,
I think they do it on a as needed basis because they have so few participants.
Okay. And the reason I was asking is, Cigna is clear that they can accept, file feeds or multiple file feeds, that they can accept an Excel data sheet, and then they can take manual entry into their website. UHC can take the file feed and they can take entry onto their website, but no Excel is mentioned there. And then Aetna says they can support, everything, but doesn't clearly spell out what everything is. So there's a little bit of variation in there. Doesn't impact us as, us that are using Oracle, but for, Children's Board, some of those other outside agencies, I'm not sure if there's impact to them.
But for the most part, I think they do most of it
Manually?
through their website. Yeah.
There's that is across all three that is available to them. Yeah. I'm thinking I'm probably going to be first on the list. I'm just going to put it out there.
Everybody's going to lean into you.
Yeah. I'm going to put Cigna at a 14. And again, it's because of the flexibility in their responses, the thoroughness on their responses, the fact that they're upfront, that they have limitations on their file. I appreciate that level of knowledge up front. And I think they're going to be very flexible in working with the county to help us to evolve going forward. I would say I would put Aetna second. I would put them at a 12. And again, they answered the questions. They were definitely very participative and gave information. Not quite as thorough, I think, as Cigna did. There were a few more limitations or question marks for me in that data. And then for United Healthcare, personally, and again, I might come in lower than everybody else on this, but I'm down at an 8. And that's because that check and balance that's critical to us for the discrepancy reporting, and some of these other capabilities, it's just not there. And I should also note with Cigna that with that achievement process, they are taking it on in full. So.
That's not taken on the full?
Oh, not in full.
No, not in.
Okay, sorry about that. Who was taking it on in full? Maybe I reversed it. I thought somebody was.
I want to say it was Aetna.
Was it Aetna? Okay.
So Aetna.
I might have my columns reversed on that.
But I know it wasn't Cigna.
Okay. I actually don't know if it or not. I gotta figure out which column is which. Sorry. Let me just take that. Video.
I had Cigna at 15 because I'm not comparing the two against each other. I'm just answering the questions based on how they answered, and they said they could do all the capabilities. And United, I put it in an 8 as well. I subtracted 5 points because they didn't provide the plan, and 2 points because of the discrepancy report. And then one more, there was something else in there. I can't remember why.
Is the implementation plan part of this area, or is it?
Yes.
The only,
Work plan that's separate.
The implementation plan's pretty generic, right? They all have outstanding and exceptional ratings from the people that they've worked with. Implementation's implementation.
Our references was the other category.
Yeah, there are detailed implementation plans in the files.
I'll do 9 for United because I have a point deducted, but I don't know why. So I'll just say I'll deduct 7 total. So 15, 15, and 9 for me.
15 in there?
Yeah, 15 for Cigna, 15 for Aetna, and.
Oh, okay. I'm sorry.
9 for United.
Okay, thank you. Sorry.
To answer your question about achievement, Cigna provides reporting to allow the county to support achievement. Aetna has 2 options, including a full service program and a focused program to meet specific needs. Option 1, our most complete and cost effective program, options, provides you with a full range of services, including identifying, validating, da, 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 da. Option 2, stop payment only. Our stop payment only option automatically stops payment. And then United said, self-funded customers are responsible for their aged outstanding check items. Customers carry the sole responsibility for determining whether ERISA laws or unclaimed property laws are applicable to them, which ERISA is not applicable to us. Customers receive a monthly report. Aged items are not fully customer funds only upon clearance. I think Aetna was the only one really
That's what I
offering.
did, yes,
a full
and
service.
United Healthcare will also be sending letters to the payees. Yeah, so they'll send
Sends
a
a
letter
search
to them
letter
as
to
well.
each payee.
to
Yeah,
do it, so.
that's 6 months.
When I was reviewing, the one thing that stood out to me was the inability of the discrepancy report and also the inability to, although you said they would work with, third-party vendors, they didn't really say yes on that questionnaire. And I know we have some third-party vendors that, we directly work with that we would like that capability. So I felt that both Cigna and Aetna answered equally. And I would put it 15, 15, 12. Yeah, no, 15, 15, 10 is what I meant. Sorry.
So 15, 15 Cigna Aetna, and then.
Yes.
Okay, I got, sorry, just taking notes here.
No worries. I did not find any issues with anything reported by Cigna other than they said there could be data restrictions that impact downstream applications, but you said that wasn't a critical thing. It's just helpful to know. So, but they did not provide any comments with that. So I was going to give them a 14, but since you said it's not a critical piece, it's just helpful to know, I will give Cigna a 15. I think Aetna had a couple of things where they said no, as far as like the weekly reporting, the prior authorization piece, and some of the others that like the threshold on the number of changes and things like that. So I would not feel comfortable giving them the highest score, and they were not as thorough in their answers as Cigna. So I would say a 13 for Aetna. And for United, the fact that they do not do the discrepancy report, which is a really big deal. They inadvertently did not include their implementation plan. So we have no way of knowing if it meets the criteria of implementing the project. So for those reasons, I would give United an 8.
I can go next. I didn't see any issues with Cigna submission on this area, so I would say 15 for them. Because of the report issues or responses to certain reports with Aetna, I would put them at 14. And then due to the missing implementation plan and certain questions that they answered, not to County's liking, I would put United Healthcare at 9.
I'll go first, so I don't go last again. I'd go Cigna 15, Aetna 14, United 13. I don't think the implementation plan was as significant. I know you like the attention to detail, but.
Study me, you do you.
Yeah, I think the differences are minimal.
It's going to be a 15, 14, and 10.
Did you say that? I'm sorry, Lil, I didn't hear you. 14,
15, 14, and 10.
50. Okay, thank you, sorry.
Which ones, please?
Cigna, Aetna, and United. So it looks like we've got, everybody's at 15 for Cigna except one score.
And I'm willing to go up on the 15 for consensus purposes.
Everybody's in agreement for 15%?
Yes.
Yeah.
And now we've got 112, 113, 3 14s and 2 15s.
I'll be willing to come down to 14.
And be willing to go up to 14 and minus 13.
Are we saying 14s? Is everybody good with 14?
Go 14.
I'll say 14.
Yes.
Okay, 14 for that.
United, we have 2 8s, 2 9s, 2 10s, and a 13.
Average of 9.5.
Average of 9.5 if we're still doing averages.
Around up to 10, yeah.
I'd be fine with that. Round up to 10.
10.
Somebody agrees with 10?
Yes.
15, 14, 10.
Now the
Keep
fun
this up and you won't be able to do 10 for this.
Well,
All right. Now the big bucket.
yeah.
So we've got the big bucket criteria, maximum of 65 points. That's the proposer's understanding of the scope and objectives, technical approach, and the work plan presented. This includes your ASO questionnaire and the attachments associated, the PBM questionnaire and attachments associated, concierge services questionnaire, wellness services questionnaire, and your EAP and behavioral health questionnaire. I do not believe the government had any concerns or feedback on this one.
Now you're digging into the details, maybe. What they're offering, no longer are we sitting here talking about the pricing, but more of what they're offering you for a plan. Now you're not really looking at apples to apples per se, so you kind of got to look at each proposer's offerings and maybe score each of them on their own merit for what they're offering and let the points fall where the points fall here. Because you're going to struggle to sit there and compare one plan to the other to some extent.
Yeah. May I?
But I will provide some guidance here on what they've seen and the analysis of those plans, because there is going to be some stuff that is similar. So,
right. And be mindful that it includes, various questionnaires besides just stuff related to ASO and the pricing for down to have it pricing. So there is that other, detail that is in there. So, and yeah.
I was just going to say that, we went through all of these questionnaires with the exception of behavioral health, because we all agreed how intricate it was. But yesterday we went through the questionnaires and we pointed out the differences for all of these. Everybody has their proposal from yesterday, or an idea I have is we can do things, and maybe these go together, but we did go through them yesterday. We did point out differences yesterday. You have some subject matter experts in the room or technical advisors, and then even some people on the committee that I think will have some strong opinions or thoughts on. There's a lot of questionnaires here, right? We went through them yesterday, all the things. Are there things that are deal breakers for the county? Do we want to start with the deal breakers, right? What from the committee, the questionnaires we reviewed yesterday, what did you hear yesterday that maybe was like a big red flag for you or a concern? And from your technical advisors, same thing, right? Because there are a lot of questionnaires and this can be very subjective. We're not going to get to who's the best number here, right? So.
And also keep in mind what they presented yesterday may have gone.
Well, I'm speaking specifically to our presentation too, with reviewing the questionnaires.
Okay. So I want to make sure we're clear, because if you're looking at presentations that were provided yesterday, that may be a little off book from what you received in those proposals. Like Scott talked about, if they offered a little dangling carrot that was off from what was submitted as a proposal, while that may be great and something we could negotiate after, it's really not something that should persuade your scoring if it takes away from what they offered in their proposal. That is something that you can consider if it's a negative to their proposal. That is something you can consider in your scoring, because that's not what we understood in the proposal, and that's a problem. So you want to keep those things in mind. And then you want to consider, and this is where you're going to lean into your technical advisor. One of our requirements was what we have or better was what we put in the proposal. So if they're not offering a plan that is equivalent to what we have or better, that's a problem. Okay? And this is why this part's going to be the hard part.
Save the hard part for last.
No, I think we did it in reverse. Don't you normally want to knock out the hard one at the beginning?
Oh, no. We saved the best for last.
There you go.
Or everybody was going to quit on me and not come.
We had to get everybody to come back today. Should we just bring
So
up?
do we want to have you kind of,
Well, we did that yesterday. I think we should start with what to the people that this is very committee and technical experts or technical advisors. What is mission critical? Let's start there and see if we can eliminate.
Or create an appropriate
Thank you.
number based
Yeah.
on,
That's better. Thank you.
based on how important that particular.
Evaluate.
Yeah.
I have a few.
Okay. He's gonna jump.
Prior authorization. Being able to choose prior authorization was one of them that got clarification yesterday, but they, and United Healthcare said no, we couldn't choose which services require prior authorization. Narrow networks. Aetna said no, they don't offer a narrow network. They did clarify yesterday, but they said no in the summary. Removing a particular provider from the network.
Start.
Are hospital-based physician services affiliated with network hospitals contracted? And United and Aetna both said no. And that opens up the possibility for employees or members to start receiving out-of-network bills from in-network hospitals. So that was a big deal.
Can you repeat that one?
So if let's say you go to an emergency room, you have to have emergency surgery and an anesthesiologist puts you to sleep, that anesthesiologist may not be in network, even though you're at an in-network hospital.
So for translation, that means they might face higher costs. if there's
You're going to
no
receive an
cap or-
out-of-network bill from the anesthesiologist and an in-network bill from the hospital.
And they could balance bill.
Okay, and which ones responded that that was the way their system would work?
At non-UHC.
Correct.
And in an emergency situation, an employee may not have a choice.
Correct.
I'm gonna zoom out for a second. That is an excellent example, Mike. I think there are some protections in the state now related to emergency room. I'm gonna expand it to what if I have a planned procedure, right? I'm going in for a knee replacement tomorrow. And I thought that I did all the homework and even because it was planned, had time to check the anesthesiologist.
You're amazing.
Then I get in there and then that guy was sick and so somebody else is doing it, right? So everything Mike said applies. I think there are a little bit more protections in a true emergency situation, but it could absolutely happen in some sort of planned, that is still true for multiple different touch points of care.
And couldn't there be some more protection because of the new No Surprises Act and transparency?
I think that generally speaking, yes, for the purpose of what is the greatest protection to your employees, it's knowing that the carrier is controlling that. But yes, there are, absolutely, yes.
If we wanted to bring in a third-party specialty pharmacy network, we were told no by all three. We couldn't do that. If we wanted to have a consultant look at the specialty pharmacy drug list to determine what goes on the formulary, Cigna said no. United Healthcare and Aetna said yes. The 1 or 2 time grandfathering for newly issued scripts, Cigna said yes, and United Healthcare said no.
Explain what that means, please.
Right, so do you want to,
Doesn't matter.
no, go ahead.
So, and this could happen with an implementation of a new plan, or it could happen with, a
Change in
dropped
formulary.
pharmacy
Formulary
from the
change.
formulary. So let's say, currently, something's gonna be dropped from the formulary January 1st, 2025. Our vendor notifies the employees and the providers for all of those affected employees in October, November, and December. And then in January, or let's just say, January 13th, the employee goes to CVS and hands in their script and they said, that's not covered anymore. Well, our current vendor and I think all of or did Cigna and Aetna, or did Aetna and United Healthcare say no?
Correct.
Okay, so Cigna is saying that they would continue that service in that when an employee goes to CVS on January 12th, they would go ahead and grandfather them in for either a one-time, 1 month so that they could get back to their doctor and get a new script written. Sometimes they'll do it even for like low-cost generics or whatever. They'll do it for a 3-month supply because it's a maintenance medication. And then from an implementation perspective, that's very important because we want to make sure that if we are moving to a new vendor, that employees are not blindsided, even though they're notified in October, November, and December that that particular medication is not going to be on the new formulary. We like the idea of some flexibility that the employee can get it one last time. So that's what that means. And it really does become an issue because generally all vendors update their formularies at least once a year, most of the time twice a year. You would know that, of course. And so whoever's going to be affected, they're going to get notified. So it really could affect a lot of people. So that's why we asked the question.
And people don't typically go to refill their script until they're out of meds.
Usually,
Or read their letters. Said, hey.
We kind of hint around and say, go get your last 3-month supply. And then, do that on December 27th.
Yes.
And then you've got 3 months in the next year.
It's out of sight, out of mind. We don't want someone to not be able to get a drug if they need,
Absolutely.
while they're waiting for.
And it's kind of just carrot stick, right? Like how are we wanting to, like, what's the culture? What are we doing?
Right, yeah.
I wouldn't say it's a deal breaker with the other two, but it's a nice to have. And it is something that we do have currently.
And it definitely would then impact potentially the employee experience.
Yes.
Certainly.
Plus, we know the formularies.
It's the benefits team who has to
So
take that call.
it's definitely going to affect members because the formulary will be different between the three.
Yes.
And it's not just like an implementation, like, so formulary is different between the three. So that is when you're changing vendors, like that's absolutely the highest touch point or highest opportunity for change, but formularies change with all of the carriers. And that is not always aligned with your contract, right? So, or your plan year, right? The formulary could change during the year. So this could be, the most disruption would occur certainly in the beginning of a plan year at a carrier change or formulary change, but formulary changes can happen anytime.
And then these weren't deal breakers, but concierge service for United Healthcare doesn't offer or discuss potential alternative treatments or options with providers on behalf of members. They also don't provide any program support. EAP doesn't provide any program or support for appointment scheduling support. And then Cheryl, you may touch more on this, but I saw that the wellness funds do not roll over for Aetna. So it looks like it's a use it or lose it that year. I went over a lot, but that was all I had.
So I'll say my deal breakers, and pardon me as I kind of flip through my pages here as I find them all and try and read them. The ones that I starred, ditto of what he says. The ones that I starred previously, that I find is just, sorry. I had double starred this, the ability to remove a provider. That really bothered me when I read that. A lot of times I think of experience of our employees. So I'm thinking if an employee has a bad experience with a provider, and we hear this from multiple employees, you know, that's something that we would want to say, hey, we don't want, and we've had that happen with the AP providers, where we've said, we want to remove, never send our employees to this EAP provider again. And if we didn't have that ability to take that out, people might still have that experience. So I could go into more detail on why that bothers me, but I won't. The other ones that I starred, I'll say the wellness funds, yes, Aetna doesn't roll over. Not only that, United Healthcare did not meet what we currently get. They only offered 175, I believe.
And can I just point out that the good point on they don't roll over, but you'll probably use them all. I don't know that that'll ever, like we said earlier, you won't ever have money left over at the end of the year. That is an
true.
important.
However, I will say we did experience that during 2020 with COVID.
Well, hopefully that never happens again.
Yeah,
Fair.
that never happens
Yeah,
again.
yeah.
But if something like that should happen again, we need to, you know, we want that ability to roll it over, you know.
Okay.
Hey, even if it's $10,000, of
course.
I
Yeah,
want
of
it
course.
for the next year.
Yeah, like the flexibility. Yep.
Yeah. So,
You can't keep having conversations off on Becky. You can't.
PCORI, can I ask advisors how important that is? Because I noticed that Aetna said no to the PCORI.
The same question.
Yeah, question.
As far as, what was it, the reporting?
Yeah, they said they weren't able to, again, we got to go with what's in there. The questions were in regards to the ability to provide the reports, and Bendy can speak to, and I think, let me try to rephrase. Bendy, I'm going to ask Bendy to speak to the level of importance for the county, but there are some fees that you are required to pay the federal government on behalf of the plan.
Right.
And there are very specific reporting requirements for you to be able to determine what that number is and file that on an annual basis. And some of the proposers responded that, and I think it was Aetna that said they couldn't provide. Now, I can tell you that all of our clients, whether they're public sector or private sector, self-funded plans, all have this reporting requirement. All of the carriers can give some sort of data sets for that. Like, I have no concerns there, but I think we asked the question in a very specific way because there's a very specific way you need it, and we don't want that to cost extra. Did I summarize that?
Yes.
Well, okay, but go ahead.
And with the reporting, there's different ways that you could calculate the amount, and, you know, we'd like to have the backup for that, right? And right now, the way that we file, which is, you know, allow us to pay the least amount in fees, you know, with Baldwin Health. And we want the backup from the provider. Our Oracle reporting right now, we don't get the detail based on the dates and actual date when someone enrolled, when someone left the plan. So we get that from the provider. And right now, you know, honestly, we get, and this I think was under the non-proprietary, but Cigna provides a snapshot report, which is not the method we use. And we go by Baldwin's information that they provide, but we don't necessarily have the detailed backup in the event that we're audited. That's the concern there. Okay.
So that is of importance to you then.
Yes, and the other one, okay, they would provide snapshot and the factor method, which is what we use, the factor method. That was United Healthcare. And that's not that they wouldn't provide, which would be, again, we won't have a backup then unless we're able to do something internally different.
Yeah, so maybe going back to, I think Christy or Sakina called out for us earlier that this is like, everything about this was we asked them to give us at least what we have today or tell us where it's not. And so I think one answer is you'll at least have what you have today. The other one was you'll have what you have today or your preferred. The other was no. But it is, I agree, a very important question.
Sorry.
go through which one was which of those categories again, please?
So Aetna's response, and again, I want to preface it with, we feel strongly that Aetna could give you something, but it may not be exactly what, and again, we have to go by what's in here. Aetna said, no, they cannot give you what you need, or at least what you have today. Yeah, and no comment, like there was no additional comment. UHC said, we can give you what you need, or we could even give you what you're asking for. Cygnus said, we can continue to give you what you need.
What they give us
What
right
you give
now.
us today.
And we were clear in that what we needed.
Yes,
It's very, I just want to make sure, because we can't set the expectation that they know what we needed without, we can't set the bar without telling them what the bar is. That's the
We
detail about what.
determined we want a custom report based on what the IRS methods are.
Yeah.
The question is specifically, it says, do you offer customized reporting for query and reinsurance fee filings?
And then they commented and gave, and
so
industry speaking, that is not an ambiguous question. That is a very standard, what can you provide and what are the acceptable calculation methods?
Just making sure we're on the same
Yep.
page and that we're not setting.
Yep, now, and just to kind of, with that question, going back to Aetna, do they provide custom reports? So they're answering no to that, just to be specific, right? Not that they can't provide us anything, but they didn't provide any comment. But as, they mentioned that, I'm sure they could provide something, but.
We have to go by what they said.
Right, but they said they couldn't provide us custom reports, right? They can't provide custom reports.
Okay, the other, going down my list, Aetna does not provide 1094 and 1095 services.
We're actually contracted elsewhere for that, so it's not relevant.
Not today.
Not today, but how much do we pay for that
I wanted that
contract?
in there just because of the future. We don't know what happens in the future.
How much do we
But
pay
it's
for
not-
that contract if we were to get these services included?
Then
We
I
could
would-
end that contract and save the county.
And I would say for that purpose, this question is way too generic because the amount of information that goes into calculating, printing, corrections, additional filings, I mean, that's a very large scope service. So you do 1094C, 1095C, it's not a sufficient question.
Well, I'm just saying that, and I said no.
Deal breaker.
Well, I'm just telling you what my deal breakers were. Thank you. All right, very good. And the EAP seems very similar. There was one more response, and that is the pharmacy rebate pass-through. Aetna on here says they do not offer a 100% pharmacy rebate pass-through that is a flat fee. So I'm like, okay, do we lose money with that? Probably. And I guess I'll stop there because I could just keep flipping through. I will say this, I don't see as many deal breakers on the Cigna as the other two. If that's a 30,000 foot overview, look down on it, right? So.
Well, I think that's what we're hearing from, because I'm kind of writing down everybody's deal breakers and trying to write down what the response was from different ones, because again, you guys.
And I think
swim in
that's
the pool every day.
the
so,
really
yeah.
hard part here is like enhancements are great and no, hands down, all of the responders came to the table with even the incumbent, like they all came to the table with enhancements and we asked them to do that and that's great. So, but we have to kind of flip it now and look at it as, are there things we can't live without? Because that's important.
And I wanted to raise the point that Mike was given from our side. We seek flexibility as a key, super important factor as we are doing plan design and what's best for the employees and for the county. So if you remove that flexibility and box us into specific, it shall be this way, then it makes it very difficult. And customer service to employees is critical for us as well. And when that's limited, then that presents a problem for us as well.
Yeah, so on the concierge, actually, I was just going to say a couple things on that. The concierge service, not the 24-hour inability of 24-hour, especially for our firefighters that work overnight. that can't make that phone call while they're working and get the help that they need. They're gonna have to. Yeah, so that was definitely United Healthcare. Yeah. But as far as the flexibility and going back to, and I'm not trying to bring price back into this, but I want to kind of talk about how I read through that offering, the offerings of the buckets of money. We in the past have always had, we're going to give you this much for this, this much for this, this much for this, and this much for this. And we've never been able to move those buckets. There are times where we wish we could have moved the bucket. So I really liked seeing the chunk of money coming in and being able to sit down, have that align with our strategic plan every year and say, oh, okay, now we can move this bucket here because this is more important and that is more important. And I really like that. So looking at the overall chunk of money, of course, we saw who was the largest chunk of money provider. And that to me is a nice bonus. I'm trying to be so generic, but that was really, I think that's important in our strategic planning,
It also gives you the flexibility.
Yes,
She was just discussing.
exactly.
Which is important, but all of the proposers did offer something, some allowance, just different levels.
Correct.
And they all seem to offer it in a way that it could flexibly be used. So.
But it's also different terms, right? One of the.
I would argue some of that language is more flexible than others, right? Some says it's very specific to wellness. Some says it's very specific to the diversity and the minority owned business. Some is like, hey, all of these things are together. So yes, they are. Yeah,
One is just
one is a short-term period. So they're definitely all generous and they're definitely all innovative. Some of them, that language narrows down what you can use the money for more than others. Right or wrong, like I'm